Good afternoon, everyone. Welcome to the National Symposium of Drug Elution, organized by the Vessomag. I would invite Dr. Amish Matre, sir, the Secretary Vessomag, to give us the welcome address.
इसको ऑन करो. Okay. Thank you, Anirudh. Welcome teachers, colleagues, friends, and our industrial partners to Mumbai. On behalf of Vessomag, I would like to welcome you all for the Mumbai's in the first annual Vessomag meeting of National Symposium on Drug Elution. Vessomag, its full form is Vascular and Endovascular Surgical Society of Maharashtra and Goa. The idea was floated in after the Hyderabad VSI Con. We had Kambedkar sir, Pai and me were sitting, and of course over beer only these ideas can be floated. So that's where we started, let's have a Society of Maharashtra, and we all came together on 24th November, the first meeting which we had, and eventually because of COVID we got little delayed, and then we formed the society. This is our third year of Vessomag. And last year we had almost 15 conferences state and in various cities, medical colleges. Keeping with the ideas of VSI, we tried to promote Vessomag, vascular surgeons and vascular societies. A few medical students showed interest in taking up vascular surgery as their future career. Especially Kambedkar sir's talk was very inspiring in Nayar and Pune medical colleges. So this is the main objectives, medical, educational, and social objectives. We have been registered in Pune under Society Trust Act and also in Maharashtra Public Trust. So everything is accounted for. All the accounts are submitted to the charity commissioners. So we are at present 30 members in the third year of our existence. Coming to today's why we are gathered, Drug Elution Symposium. Over the next couple of sessions, today and tomorrow, we have arranged an exhaustive topic of to address by some of the experts in India as well as overseas, with the hope of addressing all the issues related to the fascinating subject of drug elution. We request you as participants, as delegates, as speakers, to make it a lively session. We want a lively session. Every topic should be discussed, talked, and there should be input, queries, so that we can have a enriched knowledge when we go home. Let's make it a more interactive and lively sessions. We have, I think, Anirudh and Sir has paced the topics where we have sufficient place for discussion. Vessomag is committed to vascular education and awareness. And I'm sure in the future years too, our younger colleagues will follow the path of higher standards set by our seniors and future endeavor of Vessomag and contribute to the natural awareness and knowledge and training. Thank you for attending despite your hectic and personal schedules. Thank you for having accepted our invitations to attend this program and contribute to our knowledge and future endeavors. Thank you for our overseas faculties who have graciously accepted our invitation to speak on this topic. And lastly, we cannot forget our industrial partners who have been supporting and being a strong pillar for vascular surgeons throughout the country for our educational activities. Thank you. And we welcome you. I will forward Dr. Shekhar sir and Dr. Anirudh to take over the future process of the. Yeah. Thank you.
We would like to invite Dr. R.C. Srikumar sir for the President VSI for the presidential address.
This is my Trump's position. When Biden is in chair, Trump is acting as a president now. So when Reagan is here, still I am called as president. Thank you all. So good afternoon, friends. This is the first program of 2025. Very delighted to see you all in the city of stars. And we are in the place of stars, as Shekhar was saying in the forenoon, Juhu. And we are seeing the stars of the surgery, Shekhar, Amish, and Anirudh, and our senior guys, Dr. Paresh and Dr. Kamarkar, and all our dear friends. It's very nice to see that all the states are starting their own branches or units of vascular surgeons, so that we will get more visibility and more acceptance among the community. I'm very proud to say that we have very good visibility now. That's why even the IR people are changing their name from IR to vascular surgeons. If you look at many boards in many corporate hospitals, the IRs are slowly changing their name to vascular surgeons. So that's an effect of our own work. We established as a specialty, as a society, and we got more social acceptance. So this is a very great event to spread about the awareness of vascular surgery, and we are moving from surgery to pharmacology as the first speaker. So from VSI, on behalf of Vivekanand and on behalf of our secretary, I wish you all the best and wish you a great conference and a great time in the next tomorrow, today and tomorrow, and have a wonderful evening get together. Thank you very much. Wish you all the best.
Thank you, sir. We'll start with the first session for fundamentals of drug elution. I would like to invite the chairpersons, Dr. Nupur, Dr. Rohit Gupta, and Dr. Rakesh Jha, to kindly take the first 3 seats in front. I would request them also, Dr. Rakesh Jha. Okay. I would invite Dr. Devendra Singh sir to speak on drug elution, the history.
अरे कहाँ गया? First of all, my sincere thanks to the organizing team for giving me this opportunity for this unique and learning experience. At least for me, drug elution is a learning experience. Though I am the opening batsman for this meeting, but my position is exactly like the player sitting on the bench, watching and learning Sachin Tendulkar as the opening batsman. Historical development is always very fascinating. The farther backwards you can look, the farther forwards you are likely to see. And lesson learns from historical evaluation, the key to rise, rule, road towards a progressive and permissive future. If you know the history, I think will not rukega nahi bana. Well, any endovascular meeting is incomplete mentioning the name of 2 giants who basically fundamentally started the endovascular interventions. The two giants, Daughter and Grundgich. We should also thank and not to forget the first patient who submitted herself for the first endovascular procedure. This is the story of Laura Shaw, the beginning of endovascular era. She was 82-year-old lady, suffered with rest pain, left foot with gangrenous toes, advised amputation by all. She refused. And subsequently, she was referred to Charles' Daughter. He said he will do an angiogram first and then probably he'll take a call. He did an angiogram and then he found out there is a SFA lesion, short segment SFA lesion, and he planned for dilatation of the lesion. And that is how the story started. This is the story of Laura Shaw, the first peripheral angioplasty done on January 16th, 1964 at 2 p.m. You can see the result, fantastic flow started, and the notes written by Daughter himself. Happy lady, watching her angiogram, the success story, and she was relieved of pain and gangrene. He believed if a plumber can do it to pipe, we can do it to blood vessels. Very determined. Before that, two important events in 1963 preceded this first angioplasty. While he was studying coronary imaging in cadavers, he realized that the forceful injection across diseased arteries could disrupt and expand obstructing lesion. He reasoned that it should be therefore be possible to dilate similar lesions in the leg arteries. And the second event, performing an abdominal aortogram to specifically assess the renal arteries. When he eventually advanced his catheter through a occluded iliac artery, this set him and wonder about the possibility that had a balloon been attached to the catheter. He had then association with Cook, we all know Cook Industry, and they both sat together and decided to have more and more work in this endovascular arena. He was unstoppable. Not only diagnostic, he started doing all therapeutic work also, and so much so that the surgeons became upset. He started taking cases from the surgeon. So now, very specifically, surgeon used to write in their prescription, visualize, but do not fix it. We are there to fix. But not all cases of Daughter did well in the follow-up. The reason? It was longitudinal shear force along the axis of the artery that created the problem. The solution? It would be better if all the force could be directed radially outward and only minimal or no longitudinal shear state at all. And so, the concept of idea of a balloon. Andreas Grundgich, the gentleman who brought the concept of balloon angioplasty. A balloon attached to tip of a very thin flexible catheter could be introduced into the vessel via a small puncture hole, could be maneuvered around curves, bends, could be passed through an obstruction with a minimal shear force, and once placed into position could be inflated to a larger size, applying only radial pressure and dilating the channel. The first balloon catheter constructed by him in 1971, and the first patient whom he did a peripheral balloon angioplasty was Fridge Ott, that was done in February 1974. Another photograph of balloon dilating catheter handmade by him, which was used for first iliac balloon angioplasty on March 6, 1974. Double lumen catheter for iliac balloon angioplasty. Again, one more case of SFA lesion and dilating it. The landmark story of him is that September 16th, 1977, the first coronary angioplasty was done by him. You can see his patient sitting in front of him on his favorite Vespa scooter. Master at work, both of them received a nomination for the Nobel Prize in Physiology and Medicine 1978, became one of the most successful example of translation medicines into the 20th century. Saved more than 1.5 million lives, prevented millions and millions of amputations. 1985, the black year in the endovascular era. Both of them, we lost both of them together in 1985. The story continued. Angioplasty, balloon, catheter, we always had a problem of recoil. What was required was a mechanical support. And then people started venturing more and more. They got an idea that steel arches used to stabilize tunnel construction maybe can be used for the arteries as well, and why not a stent? So the era of stenting started. The name stent, Charles Thomas Stent, an English dentist, and that is how the name of a stent. 1980, the two gentlemen, Swedish gentlemen, they met and they had a project sending a cardiothoracic surgeon and a Hans Wallsten, both of them with the help of engineer Christian Imbart. They eventually developed the first stent for the use in coronary arteries, that was the wall stent. The first implanted peripheral stent graft in 1985, Rojuas. March 1986, Jacques Piol implanted the first coronary stent graft. Very important picture. The first endocoronary stent was implanted in the men during the month of March 1986. And we see the result after 18 years of follow-up, the stent is patent. Same time across the globe, Palmer, he was there, he was very much fascinated by this concept, and he also started working, and they developed, with the help of his friend, developed a Palmer stent. The first stents were made from stainless steel, and despite their thick studs, poor flexibility showed superiority over POVA. With elimination of abrupt occlusion and a reduced rate of restenosis, confirmed in two historical trials published in 1993, Benny stent and stress trial. Ideal stent. An ideal stent should have a good flexibility, deliverability, low thrombogenicity, strong radial force, good biocompatibility. And this is how a stent structure looks like. We have studs, rings, cells, crowns, and connectors. But in real scenario, in spite of stent, we have a major issue. The Achilles heel, that is restenosis and in-stent stenosis. The problem remains neointimal hyperplasia. Pathophysiology of in-stent restenosis and stent thrombosis, I think all of us know this. Attempt was made to cut down these kind of restenosis or neointimal neoplasia by cutting balloon with the help of heparin-coated stent, with the help of antibiotic-coated stent, but not of much use. And then the concept of drug elution. A promising toy in the millennium has come. Drug is eluded by either intraluminal drug delivery devices or by an extraluminal drug device. Drug eluting stents work by combining both mechanical support of a traditional stent and with a drug delivery system. I'm sure the subsequent speakers are going to speak more on this. The stent scaffold keeps the artery open while the drug helps prevent restenosis by inhibiting excessive tissue growth, inflammation that can occur in response to stent placement. However, does have limitations, including the potential for late instant thrombosis requiring dual antiplatelet therapy. Drug-eluted stents coated with drugs to prevent restenosis. There are various devices now. We have drug-coated stent, we have brachytherapy catheters, we have balloons, the delivery balloons, we have drug-coated balloons, we have drug delivery capsules, we have drug-eluting spheres or beads, drug-eluting films or coating, drug delivery nanoparticles, drug-eluting sponge or gel, drug-eluting microcapsules. But the success of a drug delivery devices depends on tissue binding and clearance. Many factors collectively contribute to the complex interplay between vascular atherosclerotic structure and drug retention, highlighting the importance of considering plaque characteristic in drug delivery strategies for treatment of atherosclerosis. Plaque structures and vascular systems, a lot of factors, they depends upon the drug release and drug retention, endothelial permeability, plaque composition, vascular architecture, macrophage infiltration, neovascularization, calcification, lipid core size and stability, plaque erosion rupture susceptibility, collagen content, hemodynamic factor, and matrix proteinalysis. Well, the concept of DES in 1999, Sosa implanted the first DES in Brazil, signaling the third revolutionary shift in the history of interventional procedures. The first generation drug-coating stents, the drug-eluting stents were introduced in 2002 when Cordis Johnson & Johnson received a CE mark for Cypher, sirolimus eluting stent. Next year, Boston Scientific received a CE mark for another DES named Texas Express Paclitaxel, launched in 2004. These two stents make the first generation of stent and considered the pillar of DES technology. The initial enthusiasm was shaken in 2006 when Kamenjit published a meta-analysis showing the increased risk of death and myocardial infarction related to late and very late stent thrombosis, possibly related to delayed endothelization, secondary to anti-proliferative drug elution, hypersensitivity reaction to the polymer coating, thick struts, low suitability of the metallic platform. The issues of first generation steered the wheel of research group towards better and improved product, which resulted in introduction of stent with thinner strut, better polymer coating, and new drugs. Second generations. The benefits of everolimus includes better bioavailability, less clearance time, higher cellular residence time, good absorption as compared to sirolimus. Second generation stents gave a very promising result. However, the long-term clinical trial indicated the issue of late thrombosis, very late stent thrombosis, delayed healing, and inflammation at the later stage. So, third generation stents. The third generation stent were introduced enclosing stents with either coated with biodegradable polymer or stent without polymers, known as polymer-free stents. The fourth generation bioresorbable stents. The fourth generation, instead of a metallic platform, scientists developed a stent with a polymeric backbone that would disappear once the drug is eluted. This was a unique and creative idea, and many products came into the market, but none of them could stay on the market because of the issues. Their major issues was low mechanical strength and the drug release profile. This class is very attractive and has a potential, but still under research. They are designed to dissolve and absorbed by the body gradually over time. They are typically made of materials such as polylactic acid or magnesium alloy. The potential advantages include a reduced inflammatory response, lower restenosis rate, and ability to maintain normal vasomotor tone. They are suitable for pediatric patients and those with metal allergy. There are many trials regarding the effectiveness of these DES. I think subsequent speakers are going to discuss all these trials. Drug-eluting balloons, initially developed in 1980, experiencing a renewed interest as an alternative to address the limitation of drug-eluting stent. The primary limitation of DES lies in inconsistent drug delivery with only 15% of the vessel wall in contact with the stent surface, hindering uniform drug elution. Again, there are many trials for DEB. I think we will be knowing about this more in the subsequent lectures. Porous, microporous balloons. Now, a word about extraluminal drug delivery devices, perivascular biomaterial. Extraluminal drug delivery devices and perivascular biomaterials are designed to deliver medications around blood vessels rather than directly into them. Collagen wrap, mesh devices, drug delivery catheters, drug-eluting hydrogel, then we have patches, coatings, scaffold, gels. Lastly, local drug delivery has become a prominent strategy for preventing restenosis after interventions for obstructive atherosclerosis. The success of locally administered drug is closely tied to the vessel's anatomy and morphology of the lesion being treated. As our understanding of lesion-specific therapies continues to evolve, there is a potential for expanded clinical application of local drug delivery devices. Lesson from history and ongoing advancement in the field provides a hope for improved outcome in treating vascular diseases. Historical developments are footsteps for future developments. Friends, there are more than 200 Taj hotels, but the first historical iconic Dithas Mumbai built on 16 December 1903 was the road towards a progressive chain of Taj hotels. The basis of growth of modern invention is science, and the science is almost wholly out growth of pleasurable intellectual curiosity. Thank you very much.
I think the interesting thing about the history, when I was reading through the literature, was that drug elution, these paclitaxel and all these drugs, before drug elution, we got to know we all knew it was used for chemotherapy. So one generally tends to think that it was chemotherapy and then it was brought forward into drug elution. But the actual history is that it started with, drug-coated technology first by the cardiologists before it became a chemotherapeutic agent. And because of its toxicity, it was abandoned because at that time they didn't have the technology. So the cardiologists knew that if you put, say, a paclitaxel type of drug onto a blood vessel, it can prevent neointimal hyperplasia. But they didn't have the technology, so when they used it, the toxicity was so much that it was abandoned, and then the oncologists picked it up and then used it as a chemotherapeutic agent. And then years later, it has been reborn, and now we use it as a drug-coated technology. So, in the history of evolution of drug elution, probably the balloon-coated was it preceded the chemotherapy.
Excellent deliberation, Day1. One question is, how did daughter do angioplasty or dilatation without a balloon? What was the technology he used?
With the help of a catheter. He had a lot of catheters. He was trying with the help of catheter, like he used to do all diagnostic thing first. So as serial dilatation. So he named it a transluminal dilating angioplasty.
A fantastic talk, Devendra. Really, really, really good. So just two more comments. One was Foley, whom we all use for embolectomy. Foley used to work in the same hospital as daughter. Fogarty, my mistake. Sorry, my God, getting old. So Fogarty used to work in the same hospital as a research fellow. And he had made the Fogarty catheter, and he got into trouble for doing that. His boss was not happy with what this was going on, and Fogarty used to work closely with daughter. So at night, daughter would post his cases for angioplasty. Fogarty would manufacture the balloons in his home, and he would bring them at night. Secretly, they would do angioplasties using Fogarty balloons. So the first angioplasty balloons were actually with Fogarty. And this other guy, Grundzig was, after again, his story is also the same. Nobody wanted him to do coronary angioplasty. The cardiac surgeons didn't want to do it. He had a friend who was a cardiac surgeon who said, why don't you try it? That's how the first one happened, again, late in the evening. After this happened, the professor of cardiac surgery over there chased him out of the hospital, which is why he ended up leaving Switzerland and going to the US finally.
A very good thing happens in the evening.
Vascular Surgery Department. I am here to talk about the drug elution agents unveiled paclitaxel versus sirolimus. It's a very difficult topic for a vascular surgeon as it mainly deals with pharmacodynamics as well as pharmacology.
So I have to go back to the basics. So drug-eluting stents has drastically revolutionized the outcomes in coronary and peripheral arterial disease by reducing restenosis and enhancing long-term vessel patency. So the aim of this talk I will be concentrating more on mechanism of action, pharmacological action, as well as the clinical efficacy, as well as the safety and long-term patient's outcome. So, though for vascular surgeon it's crucial to understand the basics of these drugs. So, initially how it evolved, as sir had described about the history and other things, the complication in various procedures, initially a balloon angioplasty where the acute vessel closure and recoil percentage was at least 15%. So, to reduce that they have invented so many other things like bare metal stent, even that it had its complication of around 10%, from which the first generation, second generation and third generation and recently bioabsorbable vascular scaffolds are invented. But all these have a late complication of around 5%. Still vascular surgeons or the biomechanics, they are searching for the holy grail. So when we see the bare metal stent, there is this bare metal stent doesn't cause any modulation of the intima, and it leads to a progressive and aggressive intimal hyperplasia leading to late stage immitent hyperplasia as well as late stage failures due to neointimal hyperplasia. So objective is to form a new coated stents, prevent neointimal hyperplasia and avert late stage stent failure, and all my references are taken from this bioactive material. There is one journal called Bioactive Materials and it is to be published by February 2025. So the drug-eluting stent component is stent designs polymer eluded drug as well as delivery system. But later on the speakers will be concentrating on this topic. Stent designs itself may cause a thrombosis or it may induce a rheological effect which may induce a restenosis. The polymer used also influences as well as the eluded drug and delivery system. Each component may complicate the procedure. So this evolution of bare metal stent to recent biodegradable stents. So my topic is mainly on sirolimus and paclitaxel. So first generation drug is of sirolimus and paclitaxel, from which till the third generation sirolimus is the standard. It is in use. But the stent platform, which was initially steel, had evolved to cobalt chromium, and the stent stud thickness, which was initially thicker than the third generation, 0.14 millimeter, had evolved to 0.74 millimeter, and various manufacturers are there. History wise, SAR had dealt on the balloons and stents, but history of paclitaxel, it's produced from endophytic fungus, Taxomyces andreanae, obtained from Pacific yew tree. So this Pacific yew tree has the limitation of production of paclitaxel, because the Pacific yew tree is slow growth trees. So that made large scale production difficult. So they evolved to a semi-synthetic form. The paclitaxel lipophilic nature is very important for the prolonged action of the drug. So that requires the oil base and later formulated with albumin nanoparticles to reduce the toxicity. So mechanism of action, this paclitaxel acts in the microtubules, it stabilizes microtubules. So this stabilization of microtubules halts the progression of G2 to M phase, arresting cell division at mitotic phase. So this is the biomechanics, what it is actually taking place. When you see the paclitaxel, it acts in the predominantly during cell division in mitosis phase of the cell cycle through centromere impairment, induction of abnormal spindles, and suppression of spindle microtubule dynamics. Whereas sirolimus acts in P27 as well as mTOR. mTOR is the mammalian target of rapamycin. So this specifically acts in the different pathway. It inhibits from synthetic phase to G phase. So action in vessel wall, how it differs from paclitaxel and sirolimus. Paclitaxel prevents excessive proliferation and migration of vascular smooth muscle component. This vascular smooth muscle component is the main culprit in producing the neo-intimal hyperplasia. So inhibiting vascular smooth muscle cell is the main target of these both drugs. So the paclitaxel acts specifically in vascular smooth muscle cells, as well as the cytotoxic effect on vascular smooth muscle. There is one mechanism called mitotic slippage, where it briefly arrests the G1 phase of cell cycle. This effect curbs excessive vascular smooth muscle proliferation and migration. The other mechanism of paclitaxel is senescence, cellular senescence, that is the premature aging of the cell. So this also inhibits the vascular smooth muscle, as well as it inhibits glycoprotein VI signaling. This reduces platelet aggregation, thrombus formation, minimizing clotting risk post angioplasty procedures. So apart from the paclitaxel, now it's the sirolimus drug eluting stents. All these are all molecular basis, which is very difficult for me to understand, but I am here to deliver a lecture, so I prepared this with lot of difficulty. Yes, sir. So inhibition of mammalian target of rapamycin pathway. This sirolimus inhibit mTOR as well as binding to FKBP12 forms a complex that blocks mTOR-C1, disrupting cell growth signals. So the cell cycle arrest occurs at G1 and S phase that inhibits vascular smooth muscle as well as the endothelial cells. Endothelial cells safeguards the restenosis process as well as rethrombosis process, but sirolimus destroys both the protective layer of endothelium as well as the vascular smooth muscles. Inhibition of mTOR-C2 potentially affects endothelial cell survival and cytoskeletal integrity. This cytoskeletal integrity is very essential to maintain the integrity of the vessel. So this inhibits both cytoskeletal mechanism as well as the vascular smooth muscles. So clinical efficacy. When we see the clinical efficacy, due to this biomechanics, the cytotoxic effect of paclitaxel is far ahead comparing to sirolimus, whereas sirolimus is cytostatic, and the high lipophilicity of paclitaxel, it has a prolonged tissue retention and prolonged tissue action, whereas the sirolimus low lipophilicity requires. So this has to be encapsulated within a nano carrier particles. So efficacy of paclitaxel, it's a smaller luminal loss is occurring in paclitaxel, as well as more frequent luminal enlargement. So paclitaxel has better effect than sirolimus, but still we prefer sirolimus because of the complication and the adverse effects of paclitaxel. The paclitaxel has more anti-cancer effects on the person itself. So safety wise, potential arterial downstream tissue injury due to narrower therapeutic range and theoretical concern for distal embolization and systemic toxicity, whereas sirolimus wider safety therapeutic range. But all this experimentation was done mostly in coronary arterial diseases, less experimentation on peripheral arterial diseases till date. So paclitaxel versus sirolimus, the comparative efficacy, paclitaxel show more potent anti-proliferative effect than sirolimus, but has higher risk of adverse effect, that is distal vessel embolization. This mechanism, only while I am going through this complication of distal vessel embolization in stent is even in drug eluting stent I came to know. And there is also intimal hemorrhage, persistent fibrin, increased inflammation, whereas the sirolimus, though effective, may lead to distal embolization, particularly in higher doses. So dosage also should be properly monitored while designing these drugs. Cell apoptosis, paclitaxel induces more cell apoptosis, inhibiting vascular smooth muscle proliferation and migration. Sirolimus is more effective against endothelial progenitor cells. This endothelial progenitor cell is a protective layer. So the other, as I have already mentioned, the lipophilicity and drug retention, paclitaxel have better uptake and retention at target sites comparing to sirolimus, and distribution. Sirolimus is evenly distributed across the artery, while paclitaxel show uneven distribution, potentially causing localized damage to the vessel wall. Hypoxic environment and atherosclerosis. Sirolimus inhibit hypoxic cell proliferation in vitro. It is just in experimental stage. It is not proven in human beings, whereas paclitaxel efficiency is reduced in hypoxic conditions. So when we see the gene expression, paclitaxel upregulated genes related to inflammation and apoptosis, while sirolimus did not have these effects. So paclitaxel have narrower therapeutic window and may cause more harmful vascular effects. Comparative study, when we see the paclitaxel versus sirolimus, no significant difference in segmental luminal loss or MACE between these two drugs. Similar 1-year target lesion failure between restored paclitaxel and sirolimus. All these differences and experimentations are from first generation drug eluting system, not on the third generation system, where sirolimus alone is used, paclitaxel is discontinued. Angiographic outcomes, paclitaxel shows significant less late luminal loss and higher rate of luminal enlargement comparing to sirolimus, whereas in meta-analysis, though paclitaxel has adverse effect, there is no much difference between 1 year, there is no lesional failure between paclitaxel and sirolimus, and meta-analysis, paclitaxel use is associated with higher rate of late luminal enlargement, suggesting better vessel remodeling, which may be linked to cytotoxic effect of paclitaxel. So safety, when we consider safety, paclitaxel delivered via semi-compliant balloon. This initially I was discussing about the stent, now the drug eluting balloons were be routinely used for peripheral arterial diseases. So this is about the balloon which delivers the paclitaxel, is encapsulated in hydrophilic excipients to enhance distribution within the vessel wall and prolonged therapeutic tissue levels. It may be extending up to 2 months, whereas prolonged retention can increase the risk of adverse effect like intimal hemorrhage, fibrin deposition and medial necrosis. Preclinical and animal study findings, the cytotoxic effect on vessel wall with a potential embolic complication from drug and excipient particles causing downstream vessel necrosis as well as embolization. Apart from embolization, the distal vessel getting necrosed, leading to inflammatory reaction, and various studies like impact deep trial and Constantinos et al., all these studies shows various results, but the concluding part is initial studies raised safety concern, but recent research suggests paclitaxel coated devices may be safe with proper usage. Ongoing RCTs are needed to definitely assess the long-term safety and efficacy of paclitaxel in peripheral arterial disease revascularization. So safety profile, paclitaxel eluding stent may cause incomplete healing, increased fibrin deposition and medial cell loss, potentially contributing to long-term complication as late stent thrombosis and persistent inflammation. Sirolimus shown more favorable long-term safety profile with lower rates of stent thrombosis and improved healing. So the newer balloons are dual balloons which has both paclitaxel as well as sirolimus in 1:9 ratio, and they are encapsulated in biodegradable nanoparticles for prolonged drug distribution in vessel wall. So this is the, I think the next speakers will be talking on the recent advances. So based on this experimentation, the inhibition of smooth muscle cell, promotion of endothelial cells is the main results we have found till date. The other things like integration function, release plaque, repair lesion environment, all these are still now they are studying these effects. So when we introduce a stent, there is an injured endothelial layer as well as inhibition of smooth muscle cells. The blue and red dots, the bioactive molecules and cell proliferation inhibitors play the major role in any stent, drug-eluting stents. So take home message, as I have already mentioned, paclitaxel acts more like a razor blade, whereas sirolimus is more like a trimmer. Though paclitaxel is very sharp and it can have a better results, the complications are more with paclitaxel. So the recent drugs they use, they prefer sirolimus comparing to paclitaxel. So this bird is native of Mumbai. We fly from Chennai to we explore this area Panavel to take this oriental dwarf kingfisher. Some 6 months back we came to Mumbai. That's the connection of this picture with this place. Thank you.
Thank you, Day1 sir. Thank you, Elution sir, for nice and elaborate talks. I thought these are very boring topics and you justified your topics very well. And it looks like you took all the efforts to make this topic very interesting. Just a question, what's your personal experience for using drug-eluting balloons and stents?
Till
Personal
date I have used only balloons, especially for SFA angioplasty.
Okay.
I never used drug-eluting stents till date.
Sir, Day1 sir, your experience?
No, I have not used. I think people who has used it.
So that's in this category. I am also there. So this conference is for that only. May I put this question to audiences? How many of us has some exposure for using drug-eluting balloons and stents? There are quite a few, and who will like to, maybe after the conference overs, by tomorrow afternoon, we'll raise this question once again, how many want to use it now? So that should show the effectiveness of conference if the number increases. Because for me, if I'm using, I'm treating most of my patients are private patients, explaining them that this is POBA, simple balloon, which results in the same contrast opacification of blood vessels. And when I am using drug-eluting balloon, which costs almost 70K,
Yes.
it is also showing same picture. What's the difference? So explaining them, and it needs awareness. It needs awareness. Then only we can justify using drug-eluting balloons or stents. Why they are shelling out more prices for the same thing, same result. And
Why we have kept this topic of drug elution is that the jury is still out. We have a talk on Basel 3. If you
Right.
listen to the results of Basel 3, you will be more confused. Yes, because it was out to prove
Right.
some things, and it has proved something totally different.
That was the whole idea.
right.
Now, those who have designed Basel 3 don't
Right.
want to believe what their trial says.
Right? And
That's
that's
going to be an interesting thing. So, all those questions hopefully will be addressed as we progress with our meeting.
exactly, and that should be the last question. Take home, how many want to use now drug elution in their own practice, and that should be the whole point.
Maybe tomorrow the number will increase.
That might be a possibility.
So keeping to the topic, one question. Sir, if you are doing a femoropopliteal lesion and you have a sirolimus and a paclitaxel balloon in front of you, Which would you use?
We have used only paclitaxel till date.
Thank you very much, sir.
Dr. Allen, question is, with all this kind of paclitaxel, causing apoptosis, have you come across any situation where there's been aneurysm formation in the later stages?
I have used around six,
No,
for six cases.
in your reading of literature, whether you are seeing that, because one of the things which I remember Eluvia, one of the observation is that where they have used the drug-eluting stent, they have found that there is dilatation of the vessel as well as there is a kind of a halo which comes around it, which goes and explains why this is happening in that area.
Maybe some few other speakers, they are waiting to talk on complications.
Yeah.
Just a small question. So, according to your talk, what we reach the conclusion is that sirolimus is better than paclitaxel.
Third generation, still sirolimus is used.
Yeah.
Paclitaxel they are not using for second generation or third generation. With only first generation they have stopped using paclitaxel due to systemic complication as well as the distal tree getting necrosed.
Yeah, sure.
That is
Yeah, but all those tissue necrosis and all, those were all in the experimental stages. Yeah.
sirolimus has that safety margin.
Yeah, yeah. But if you look into the cath labs, you still have got both the balloons available, and paclitaxel coated balloons are also. And yeah, and yeah. But you see, there are a lot of newer meta-analysis which has come up even in the peripheries, which shows that the study which was published, which stopped the uses of paclitaxel, has a lot of drawbacks in that study. There were loss of patient follow-ups, all-cause mortality, which was followed up at 5 years. They actually didn't know what was the cause of mortality. They actually told that all it's related to paclitaxel. And so there were a lot of drawbacks which were put in, and there were a lot of future studies which were published, which shows that paclitaxel does not cause higher mortality. You also showed that in the studies.
If I remember, they had come after this meta-analysis, that those who have a life expectancy of 2 years and more, maybe you should not use paclitaxel, but those who have a lesser life.
Yes, sir, one of the study has mentioned this.
This is the Constanos.
And one more challenge was to deliver this sirolimus. They used to have some difficulty in technology to deliver sirolimus over paclitaxel, which they could somehow manage to do it by nanoparticles. That's why these days more of sirolimus than paclitaxel.
I'll just make a comment with regard to personal experience with paclitaxel embolization. So we've had one of those cases, difficult SFA opened up, and we decided we'll do a DCB, good outflow until then. You do the DCB, it was a paclitaxel balloon, whole thing just shut down. Distal trash. I've seen this happening live during another conference in Singapore as well. Nice runoff, you do the DCB, it shuts down. Again, paclitaxel. So this is personal experience. There have been other DCBs where we've done it, where we've not had this problem. But this fits with what Ilan is saying and fits with the cardiology experience, that you do tend to take out small vessel runoff with paclitaxel embolization, which may not be relevant for all patients. For some patients, you do lose those small vessels which do matter, but maybe for others it doesn't.
Absolutely, Robbie, because paclitaxel, if I were reading the literature, it does form clots, and it has been shown in the animal studies, a lot of animal studies, muscle biopsies. It has been shown, found in all the microvessels, a small quantity it is found over there.
Sir, when I did one TBL with the paclitaxel Lutonics way back, and after dilatation it just shut, and I had to re-dilate it with just plain POBA, and nobody had answers why, whether it's inflammatory reaction, shut down or whatever. Correct.
Sir, it is. Sir, three things regarding the halo sign. Up to 16% was the degeneration in one study. Constanos, because of which FDA had withdrawn in 2016, 2023, they have again recommended that you can use. Paclitaxel, apart from that, the polymer used to bind it to the balloon is also causing thrombosis. So when there is no polymer, there is, the same drug, the same device, with different companies have different binding things, urea or polyglychloric acid or fluorines. So they have a higher propensity of causing the thrombus also, rather than the drug itself. The third thing is safety profile. They said a 6-150 stent can deliver only up to 10 mg of the drug, while for cytotoxicity they need 300 to 400 mg. So that's why per milligram the surface area of the stent was lesser because of the open spaces.
What they have realized is the most important aspect is wall opposition, as Tapish was saying. When the wall opposition is not adequate, that is when the caking and embolization takes place. It is almost universal across all balloons. We see it very often, but we have not had clinical deterioration in any of the patients. Most often we see immediately after the procedure, after the embolization, the forefoot is a little cold. But when we know we are able to pass a wire across it, there is no occlusion, it is not a plaque embolization, by a day or two the foot is warm, well perfused. The wound also tends to deteriorate initially by a bit for the first 1 week. But I think it may also be due to reperfusion syndrome, we do not know. But most of these patients have eventually improved better than plain balloon angioplasty or stenting.
The advantage of DEB is to delay long-term stenosis. I don't think POBA versus DEB will have any acute benefits. So you might actually have an acute deterioration because of distal embolization. The main aim of doing DCB is to prevent restenosis and long-term patency.
Our use of DCBs are very clear, sir. If we want to avoid a stent, POBA is universal to all procedures, where we use a balloon to dilate a lesion. After dilatation of the lesion, if there is significant dissection, it's a long lesion, we have no other option but to use a stent whenever it is possible. If there is no dissection, we always have option of DCB. And in our experience, DCB de novo has worked far better than DCBs in restenosis cases.
So my comment was with regard to immediate outcomes of wound healing. I don't think DCB will have any impact on that.
Yes, yes.
For the longer term, you will help prevent restenosis, but for immediate wound healing, it's your POBA or your stent, which is what is going to give you your increased perfusion at that time.
It has not really worsened any of our wounds, sir.
I beg to differ, because we started using DEBs for tibials when the student did a thesis. 60 cases is what it's been published also. We did find, this was 8 years back, we did find that the wounds deteriorated and we had a slightly higher mortality. We just couldn't explain it at all with DEB, in the tibials alone. What we found was the vessel is patent, you have a palpable pulse, a wound which was red started turning blackish, and this happened for quite some time. We were very, very perturbed. We didn't know, only later we came to know that it's not just distal embolization, it causes fibrinoid necrosis of the capillaries. You need to remember whether it is paclitaxel or sirolimus works on the anti-mitotic or anti-proliferative mechanism. And the only place where a lot of proliferation takes place is in the capillaries. Okay, so these definitely get affected unless the dose of the drug is completely adherent to the blood vessels.
Sir, this was in the tibial vessels. Yeah, tibial vessels, DCBs have shown poorer results. Tibial vessels, drug-coated stents have shown better results than drug-coated balloons.
The story keeps changing.
I mean, at least...
So we come up with one set of data, we start using it for our patients, and then after 2 years, the same guys come and tell that, I didn't use urea, I'm going to use something else. What do we tell the patients? They trust us. They trust us because the story keeps changing. And the dosage in the SFA and the tibials is definitely higher than the coronaries. Definitely higher than the coronaries, and with wound healing, because of the anti-proliferative effect, there is delay in wound healing. Primary patency is good. That is why DCBs and drug-eluting stents are excellent when used for clotting
No, I would absolutely agree with that. I think DCB is for long-term outcomes. It's not for improving your short-term outcome or for healing up a wound. The best use is in a claudicant with a good runoff. I would never use a DCB in the SFA in a patient with a single vessel runoff. That's because I've burnt my fingers before. You don't want that single vessel runoff getting trashed with a DCB when all you're looking for is wound healing.
Let's move on with the discussions. Thank you, chairpersons, Dr. Rohit Gupta, Dr. Nupur, madam. Let's go to the next part of the session. I would invite Dr. Manish Rawal, Dr. Sandeep Mahapatra, and Dr. Shrikant Ghanwat to kindly come in front, please, as chairpersons. And the first speaker here, Dr. Vijay Thakur, sir, will speak on vessel preparations for DEBs.
Good afternoon, chairpersons, colleagues and friends. Thank you, Team Vessomag, for the invitation and opportunity. I would share my little experience about vessel preparations for DCB. And all these things, what we will see in the slides, are very new to the most of us practice. This is a very common algorithm most of us have for FEMPOP angioplasty. You know, all of us predilate, and as Chaitanya said, if you're happy with predilatation, only POBA, and then probably the case is over. But the evidence says, there's a lot of evidence now that only POBA versus DCB. DCB fares much better, as Robbie said, for a long-term outcome. So we go ahead with DCB for 3 minutes, and again, if you find a dissection, depending upon the type of calcium burden, you can decide whether you need to go for some kind of technology or again dilate, and if need be put a small, a very thin wall stent. If you find to begin with, I'll show you one of these cases, a slide we did recently. If there's a very heavy concentric calcification, and probably that you cannot take care of with any kind of balloon, then you have two options. Either use some device like atherectomies to debulk that, to have some kind of a luminal gain, or else you can straight away go with vasculomimetic stent. So this is how kind of, you know, all of us practice FEMPOP angioplasty. And those all of us are into practice for years have seen that these are the outcomes of angioplasty. Plenty of literature saying that primary patency is 70% at 1 year. When you read this, the primary patency of DCB is also somewhere 85 to 90% at 1 year. ISR is very huge range, you see 9 to 37%. Stent occlusion is 7.5 at 1 year and 15 at 2 years. And these are the caveats. These are the factors which decides the outcome of stenting. Length of lesion, more than 15 centimeter, more than one stent, CTO, long CTOs, female gender, probably due to small size blood vessels, task C and D lesions, and this one, plaque burden more than 60% after doing an angioplasty. Look at this slide. You know, you see nearly more than half of this lumen, you still see a lot of calcium. So this type of lesion, if you do angioplasty, I'm sure they will not hold for a long time. And this is what Rohit had a question in mind, that how do you convince your patient to put a stent or to put a balloon? Keep some pictures like this, show them occluded stents. Ultimately, it is your belief. You have to get convinced first. What works for your practice? Is stent, POBA, DEB, atherectomy? So you have to have an experience based on the science, and then you can take a call. How should you? You know, the pendulum is in your hand, the way you sway it. So this meta-analysis of more than 8 RCTs and data, they have shown that DCB certainly fares much better over POBA. We all of us agree to that. And again, there is a lot of evidence about vessel preparation. That was my talk. And these are the objectives. We need to have some kind of vessel preparations to have an adequate luminal gain. At times CTO, you know, you just balloon, and how can you expect a rubber to take care of a rock solid calcium? It cannot. So you should have some kind of luminal gain. You also do something so that long lesions, you can take care of dissections, again, flow limiting dissections. By doing any technology, use any method, you have to change the plaque, you have to change the vessel compliance. And many studies have shown that calcium is a barrier for drug absorption. So you cannot have a very calcified vessel and just inflating a balloon where drug does not get into the media, where you can prevent SMC proliferation. So these are the objectives. And again, a lot of evidence, and this Fenali study have shown kind of a calcium we have, 1 quarter, 2 quarter, 3 quarters, and all quarters. Look at this. This is a very common picture, one of our practice. This type of calcium, if you do whatever kind of stent, I think this stent won't open up completely. And this is again data that when you do an angioplasty in 2 projections, look at this one AP and oblique one. More than half of the stent, the lumen is still covered with calcium. So in such cases, not in all cases, in such cases when the calcium burden is more, when you need drug to get into the tunica media, probably you do some kind of vessel preparations. And these are the tools we have today for vessel preparations. We have a whole lot of different balloons, plain balloon, high pressure balloons, non-compliant, semi-compliant, cutting balloons, chocolate balloons, IVL balloons. We are familiar with IVL balloons and non-compliant balloons. We used to use cutting balloons for fistula angioplasties. We won't use it much for FEMPOP angioplasties, and these are the atherectomies. We used to use directional atherectomies like Hawk devices when they were introduced some years ago. No longer. Rotational devices, orbital and laser, all these devices have come. Last year, probably all the companies have come into the market with different kind of devices. Jetstream, this Diamond Stealth from Abbott, Hawk from Medtronic. This is a Spectranetics lasers, and also from BD, this Rotarex or Aspirex. And these are the different kind of qualities of these machines all these devices have. When you have a pure calcium, probably you need to have some kind of atherectomy devices. Hawk, we used to use Hawk. I don't have an experience of either Jetstream or a Stealth yet to use them. But we have a lot of technology available to use different kind of atherectomy, provided you have a case with a very heavy calcium burden. And this is the evidence. The next speaker is going to talk about the evidence and trials. There's though very small sample size. I don't see a huge sample size, less than 50, around 50 cases. It's not something you derive on the day-to-day practice. We do hundreds of cases. But still, all of these studies have shown, and it is a common sense. When you can debulk the tumor, probably you will have, better primary patency and less freedom from TMR will be higher. Again, we have different kinds of balloons, IVL balloons, scoring balloons, angioscalp balloons, and chocolate balloons. All the balloons again have shown that if you use this, basically all these balloons, they create a way, scoring or cutting or IVL, they break the calcium and fibrous tissues so that they make a way for drug to penetrate, and the long-term results are much better. And they have shown in those small numbers, but chocolate balloons a large number study, and they have shown all these criteria like primary patency, freedom from TLR, or freedom from major amputations were much better. So there's enough evidence to tell your patients also that, look, the science is this. Now the dilemma in our mind, how to choose it. Very simple. If you have a very calcified lesion, concentric or eccentric, you need to have some kind of atherectomy device. If you have eccentric calcium, you can pick it up. I think Hawk devices are much better. If you have concentric calcification all around, probably rotational or this device is much better. And a mix where the calcium and this thing, probably you can have rotational and aspiration, like orbital devices are much better in those cases. When you have long fibrotic lesions in a small diameter artery, especially in women, osteal lesions or bifurcation lesions, if you use some kind of devices, that they could be plaque shift embolizations. So in those cases, some kind of balloon like IVL, chocolate, scoring balloon or cutting balloon is much advocated. This again a good paper. They said the procedural criteria, these are very important to have a good preparation, a good long-term outcome. Less than 20% diameter stenosis at the end of whatever device you use, balloon or atherectomy or aspirations. Prolonged time for more than 3 minutes, and BSR has to be 0.9 or less. And this was again a study about the inflation time. Who have time? All of us are so, in haste, a lot of cases to do. 2 minutes of pre-dilatation in a smaller size balloon. This is what is, we have to understand, that you shouldn't go to the, but rest RBP or NBP. You have to have an opening pressure. If the lesion opens at 4 or 5 or 6, don't go to 8. They say, and the pre-dilatation has to be a little smaller balloon. If a vessel is 6 probably or 5, use 4 millimeter balloon to pre-dilate. Then 3-minute pressures with low pressure, DCB 1:1. So what we do, we normally measure on a sonography the size, the diameter of SFA, and looking at the diameter of SFA on ultrasound, we decide the size of DCB we use. And even after this, if you find some dissection, you again dilate for 3 more minutes, and you might see the dissection, it gets stuck to the wall, and you don't have to put any kind of bailout stents. This study also showed that recommended low pressure prolonged dilatation, no difference in the residual stenosis, not a long-term outcome, but it did not worsen kind of a dissection. So we have to be very careful about it, that we should give enough time for balloon dilatation. I mean, not just 1 minute, it should have couple of minutes. So I normally, if very resistant lesion, I go for 5 minutes and more also. One of the cases we did last week was, these days, because all of us who are doing angioplasties, femoral angioplasties, all of our patients have come back with using longer stents. And everybody must have had this experience, and we are also learning new things. So this was a guy, very typical lesions, very ideal case, had multi-level lesions of short segment, lower SFA, popliteal, tibial lesions. I couldn't get the picture of a pre-dilatation here. The small size balloon was used, 4 millimeter, and then long 6 millimeter. This was paclitaxel use balloon, Mosaic PB was used, and this was normal POBA. So far is doing good, no acute problems. Another case, 65-year-old gentleman, post-PTCA, diabetic hypertensive, very short distance claudication pain. He ended up, and look at this picture. Only on looking at the angiogram, we have a lot of calcium burden. And we have to use something, not only POBA will work in this case to begin with. And this is a DSA, you see a lot of calcium, the long segment lesion. No wonder, no debate about FEMPA bypass. We are not here to discuss about bypass or angioplasty. We did angioplasty somehow, and you see this, look at the calcium burden, and despite using semi-compliant or non-compliant balloon, we went close to RBP, but this was very stubborn calcium, no wonder. We couldn't open it up. We took pictures in different projections. You see AP, LAO, right, left LAO, and just to make sure that how much calcium is there. These are the cases, ideal cases, where we need some kind of atherectomy devices. We do not have a good experience in the devices. So what I did a kind of a spot stenting here, use a vasculomimetic stent there in this area, and the proximal one is DCB, and this was the final outcome. So to summarize, vessel preparation has progressed from fiction to fact. Many of us are practicing in our routine practice. It is an integral part of endovascular practices. It will become a part of an algorithms. It is important, very important key step to optimize acute outcomes, like to prevent dissections, to facilitate drug delivery into the lesions, and to bring better long-term outcomes. Thank you very much, ladies and gentlemen.
Very excellent talk.
Thank you, Rahul.
Just 2 questions. One, I really don't know what is chocolate balloon. And second is the last case which you showed. Like my experience is, we all see such calcified vessels. Patient not able to afford an atherectomy device, very common practice. And but we have taken the patient for angioplasty. And you do the balloon and it doesn't open up. And I actually avoid putting the stent, any stent here, because if the artery does not get opened up with a balloon, the stent will not be able to open it up. This is a very basic thing, which I have learned, that because the stent cannot open a calcification, that's my experience.
I partly agree with you. First thing about chocolate balloon is a balloon. There is a nitinol cage over the balloon. The balloon is semi-compliant, and the fundamental is you have to inflate a lower pressure. And because of nitinol cage, it will not create a longitudinal force, shear force, and create dissection. So chocolate balloon is a balloon in a nitinol cage with a lower pressure semi-compliant, which will prevent dissections. The whole idea is to prevent dissections using pre-dilatation. About question of the two, calcium and balloon and stent, I totally partly agree with you, because if you don't do it, let's say, if you leave it like this, there is a failure of an angioplasty to begin with. And of course you can go back and do bypass surgery, but to at least have a short-term result or a medium-term results, putting a vasculomimetic stent would give you some kind of relief. Only putting nitinol stent may not really work a little longer. Yes, Dinesh. Thank you.
So all your vessel preparations, atherectomy devices, IVL balloons and all, if the wire goes through.
Of course.
Yeah. So if the wire doesn't go through, are there any methods in the literature to fracture that calcium? For example, you have intravascular lithotripsy. Is there something like an extravascular lithotripsy? Like how you use it for renal stones, number one. Number two, especially in TBLs, sometimes you do subcutaneous needle puncture of the calcium, just to break the calcium there so that it might get passage for the wires to go in. Something like that, especially for SFAs.
To answer a question, in a very calcified lesion, you see, in fact, if you are not using any atherectomy device, we can still get away with doing subintimal angioplasty and have some result. But if you want to use atherectomy device, you have to be transluminal. You cannot be subintimal. And currently, we don't have any device to guide you. There used to be a device in past where there was a sensor at the tip of the wire, and it was a radiometric kind of a monitor outside. And the moment you go and hit the adventitia, it will show the red alarm, red beep, so that you prevent perforation. But not longer available in our practice.
You think AI would have a role in this?
I am not an expert to comment. Difficult to say.
Let's speak to Meryl.
Yeah. Yeah, Paresh.
A couple of points. What we normally follow is when you're, this is basically again brought up from the cardiology experience with coronaries, that when we are treating stenotic lesions, we always dilate for 2 minutes. If you are doing occluded lesions, then we stay for 3 minutes. That is the standard thing that we followed. So sometimes, our conventional teaching was that when you're using a balloon, you undersize the balloon, and when you're using a stent, you oversize the stent by one.
Don't.
So that was conventional teaching. So generally what used to happen is you tend to use higher pressure, so that but that higher pressure causes barotrauma. And while your patency, you might get good result initially, long term the chances of restenosis is a bit more. So that you have to be a little careful when you are doing that, and it's kind of rethinking everything that was previously taught or previously followed. And that's very important when you're using DCB, because if you use high pressure, the amount of the drug which is going to go into these cracks which have results in more concentration and more complications.
True, low pressure, longer time is a key for angioplasties.
Excellent talk, sir. Do you find any difference in the vessel preparation when dealing with the eccentric calcification versus circumferential calcification? Like as you mentioned in chocolate balloons, which are not available right now in India, but do you find any special method that you can use for your calcified blood vessels, sir?
See, Sandeep, if you can make out eccentric versus concentric, you can choose the type of atherectomy device you're going to use. If you have an eccentric calcium, probably you can get away with Hawk devices, which is directional atherectomy. But when you have circumferential calcium, concentric calcium, you might have to use one of those rotational or orbital atherectomy devices. Yeah.
Thank you, Vijay.
Would you take a plan for vessel prep on CT angio or MR angio?
Yeah, certainly on a CT angio, CT definitely will give you a good idea about calcium. So, as I said, all these devices have come only last in practice. It's very early for our market. I don't think many of us have huge experience about it, only few cases, barring few centers. So, maybe in years to come, we'll talk about this, more our experiences of using atherectomy devices. And it's going to come. It's going to be part of our practice. And CT is a good guide to tell you about it. Even fluoro for that matter. Just even you do fluoro imaging while doing a case. But time will come that all of us will have to have devices on our shelf, some kind of scoring cutting balloons or atherectomy devices to take care of these lesions. We cannot shy away from this.
Vijay, how would you choose between using an atherectomy device versus using IVL?
While preparing this talk, Paresh, this idea came in my mind. See, the IVL, we always talk about cost. Here the cost is nearly same for both the technologies. So if I have to choose, which I have done also, that I use IVL for larger diameter vessels. Like I have used IVL for aortic lesions mainly, aortoiliacs. 7 millimeter balloons, I have used IVL. So other problem is IVL, the length of balloons, IVL balloon. They are not longer length available. They are the shorter length available. So then again, when you have to use multiple balloons, the cost issue is a challenge. Yeah, Roy.
Just a comment to Paresh's question. Between IVL and atherectomy, I think IVL, the one fear with atherectomy is distal embolization. And that's one thing that concerns me with that. So even my preference, like you, for aortoiliac is to use IVL, and it's fantastic. You see this huge rock, it literally just melts away with IVL sometimes.
Yeah.
And your stent opens up very nicely. It has better patencies, but again, in a few years, the lesion is kind of back. So it's not a complete cure. So it's just my thoughts on this.
True.
When you have a circumferential lesion, using an IVL, which is going to act round the entire lumen, would probably give you a better result than, so that it's a better bed preparation for whatever else you are going to do.
Paresh, this is true for large diameter.
No,
for
SFA. I'm talking about SFA.
Even 5 millimeter SFA, you should have some luminal gain. No? If you can debulk the lesion, you'll have some space for balloon to open up. With IVL, it cracks. It doesn't evaporate.
While dealing with the eccentric calcification, when you are ballooning, the pressure is applied both to the calcified side as well as the non-calcified side. Now that non-calcified side is taking the extra burnt at the cost of the calcified, for which we are interested actually to get the luminal gain. Now if something like that design what the Medtronic guy, they are claiming for the chocolate balloon, if the furrows and that pillows design comes and that applies uniform pressure across the vessel, like both in the calcified side as well as non-calcified side, maybe our vessel preparation may improve, it feels like.
Correct. So when you see a lot of calcium, I think it is better to use atherectomy over balloons.
Thank you, sir.
Thank you.
We go to the next talk, inviting our VSI president, Dr. Vivekananda, for his talk on DEBs in SFA, trials, tribulations, and triumphs.
At the outset, I'd like to say thank you to the organizers of this meeting. Wonderful attendance. And the first one. I think over a period of few years, you would have noticed that, I don't like talking too much about statistics. Believe me, at the end of any conference, nobody remembers any of the statistics which goes around, because each of the speaker has around 6 trials which he has specifically picked up, and you have 150 speakers, all interesting topics. So we need to have a take-home point. Before going into DEB, I'd like to take a step backwards. I'm always a skeptic. Peripheral arterial disease, here to stay, aging population, increasing diabetics. We are going to be in business for a very, very long time. And we need to start handling our patients much, much better. Though we had this statistic saying that, within 5 years, more than 50% of our patients are dead. Initially, it used to be 2 years, 30%. Now it's 5 years. But I think with better medical technologies, including renal failure patients, they tend to live a little longer than what they used to earlier. So it's not just one factor. It's not one drug-eluting stent, drug-eluting balloon, or a specialized stent which is going to keep the blood vessel open. Treat the patient as a whole. Do not concentrate only on that lesion over there. So what are the options we have for treating any kind of peripheral arterial disease? You have the medical management, essentially for claudicants, yes. Optimal medical management remains the bedrock of any kind of treatment. You have endovascular treatments, POBA, stents, different types of stents, drug-eluting balloons, various other techniques. And we are all vascular surgeons. We all think and we know that the bypasses work for a little longer than an endovascular procedure. Gap is closing. And we have enough evidence with various newer trials. Now, let's not get into surgery or endovascular procedure. Our enemy, whether you do an endovascular treatment or whether you do a surgical treatment, is neointimal hyperplasia. What basically, see, as soon as you do an angioplasty, the initial recoil you get is because of the recoil. You're not able to adequately open up the blood vessel. But anything which starts happening later is always neointimal hyperplasia. Neointimal hyperplasia is actually physiological. It's the healing process of the blood vessel to any kind of injury. So to say we can prevent neointimal hyperplasia is going against nature. And you can't go against nature and win. You can postpone the inevitable, but you cannot prevent neointimal hyperplasia. Always remember that irrespective of what anything say, the body is always and nature is always 100 steps ahead of you. And let's just feel good that we are able to postpone the inevitable. So you do a POBA, you get neointimal, you can get an immediate recoil, but in the longer term, it's always neointimal hyperplasia. You put a stent, you get neointimal hyperplasia. The timing differs, but you do, and that is the reason why most of the SFA interventions fail. But does it mean that, if I do a bypass surgery, my neointimal hyperplasia is not going to be there? It's going to be there. At the anastomotic site, you're still going to get a neointimal hyperplasia. The body reacts in such a way that anything which is not native is always destroyed or it occludes over a period of time. So you put them on a surveillance and then you catch them before it really occludes. But neointimal hyperplasia is our common enemy. So basically when you do a angioplasty or when you disrupt the blood vessel, even when doing a surgery, what happens is there is a breakage of the internal and external elastic lamina. We always seem to concentrate only on the endothelium as well as the media. The adventitia slowly has been proven that is most potent thing in repair of the blood vessel, and most of the stimulus does not come just from the endothelial breakage, it comes from the vasa vasorum. So adventitia also has a major role to play, and it's the smooth muscle cells. One, it has two functions like Elan had already mentioned. One, it starts multiplying and then it starts becoming secretory. And using the drug-eluting balloons, you're trying to reduce the multiplication as well as reduce the secretion. You reduce it, but you can't stop it. Now, all of you are surgeons out over here. We've all seen how neointimal hyperplasia looks. When you've done a redo surgery, it's like a plug. You do a thrombectomy, you get a white plug out over there. Now, my doubt, I always keep arguing with people. This is a neointimal hyperplasia in a stent which was formed around 2 years back. That has got occluded. Now, that has already gone through the multiplication phase, it's gone through the secretory phase. And now you're going to put a DEB. I have a doubt over here. Now you're going to put a DEB and say, I'm going to reverse something which took place. So basically, when you're dilating, keeping it dilated for a longer time. So you're going to compress that like sponge and you're going to drive out a lot of things. But you're not going to prevent. What you're going to prevent is further neointimal hyperplasia. But what is already there is a little dicey. Unless you debulk it, it becomes irrespective of what the data says. This is a physical lesion which is already there for 1.5, 2 years. You can't say that it will go away. And just because some trial says it goes away, you have opened the artery, you have seen how it is on the inside. So, I mean, this podium gives us a good reason for us to discuss a lot of things, and I think it's a wonderful initiative. So, this is my main problem. What happens when it's already there? So, like somebody said, de novo has a better result than following a previous procedure. Now, how do you prevent neointimal hyperplasia? Do not go into the drug directly. There are a lot of things. See, what we need to remember is the kind of patients we deal with and the kind of patients that the studies present to us are completely different. They will not recruit a patient if the HbA1c is beyond 8.1, most of the studies. And very few of our patients really fall into that category. Most of their patients are claudicants, not that they don't treat. So we have a difference. So optimal medical management, optimization of the patient is of paramount importance. So let's not just think it's just endothelial hyperplasia or you giving certain drugs is going to reverse all the things. Systemic medical therapies, we already know about it. Statins, higher dose of statins does have a role to play. And cutting balloon in the primary stage itself, instead of uniformly dilating the blood vessel and fracturing all over and then causing disruption all over, you fracture it in certain places, get luminal gain. Maybe that was what was taught earlier. Appropriate sizing of the stent. Don't oversize the stent tremendously. This is to try and, in our existing practice, to try and limit the first edition of neointimal hyperplasia. Are there a lot of other strategies too? Yes, there are a lot of other strategies which have been there from before. Some have fallen by and some are coming back again. You have COX-2 inhibitors, gone. TNF-alpha inhibitors, again to reduce the inflammation, gone again. DEBs and DESs are there. Again, you have other strategies. You have the gene therapy. Coming back again. 2 Israeli companies and 1 Canadian company, they're coming out, it's there in endovascular today. And in the device guide, they are coming with vector-based therapies, which again, maybe 5 years down the line, we'll be having a conference like this saying that, newer technologies to prevent neointimal hyperplasia. Bioabsorbable scaffolds have already come in. Lot of polymers have come in. You have, like Ilan had already mentioned, progenitor cell injection directly. So basically what happens is you try and repair the endothelium. Once the endothelium is completely formed, all this process of multiplication and secretion comes down. So they did try this, coming back and going back again. Endoluminal brachytherapy, I had seen it in the coronaries being done in our institute itself, long back, known to reduce it, but again, didn't have good long-term results. There are a lot of other devices which have come in, which have tried and reduced the incidence of neointimal hyperplasia and keep the luminal gain going for a longer time. Now, in brief about the various trials. Now, at the end of this talk, you must know that, DCBs are definitely better than POBA, and it definitely gives us luminal gain and maintains luminal gain for a much longer period. The safety and other things, there are other papers which will come up with it, but definitely various trials show that at the end of 3 years, previously all the data used to be at 1 year, now you're going up to 3 years, sometimes up to 5 years. Try and remember the names at least, forget the statistics, it's very, very difficult to remember all the statistics, and we can always pick holes. And even at the end of 3 years, if you have something like 75%, that's phenomenally good. But all these lesions were less than 7.5 centimeters. Again, complex setting where there is occlusion, narrowing, calcification, like some of the slides which are shown by Vijay Thakur, you can't use DEB in the entire segment. So you need to tailor a program for the lesion. So how do you deal with eccentric calcification? How do you deal with circumferential calcification? We all know where to put DEB. I'm sure towards the end of it, we need to have a session where not to put a DEB. You have Monkeyberg calcification, you put a DEB, I mean, you're only giving him business, and that guy will know that, you know nothing, you're just interested in putting a balloon. You cannot achieve any good results when there is Monkeyberg calcification. So how do you identify that? When you see an X-ray. So when you start reading the calcium scoring, you will know where to put what device and do it appropriately. Various trials, like I told you, safe DCB register, then you have the Thunder trial, Levant 1, Levant 2, all these things definitely showed that you have more than 75 to 80%, and in Levant 2 study, at the end of 12 months, you had around 89 or 90% at the end of 12 months, and at the end of 2.5, 3 years, some of the reports have come out, almost 70%. Pretty good, stays open for a much, much longer time. But in patients who have uncontrolled diabetes and in patients who have renal impairment and who have severe infection, do these DCBs work just as efficiently? There is a huge doubt being raised about it. I mean, if you look into critique of any of these papers, just look into the other part where they give a commentary, you find that it's not as rosy as what they claim, but definitely towards the end of 3 years, you have a fairly, almost around 50 to 60% improvement in this patency compared to a POBA. So regarding drug-eluting stents, I'm sure the other speakers will come to it, various trials, and try and keep the dosage of the antimitotic drug at the minimal, because the last of regarding the toxicity has still not been said. We still have to go some time. By the time we get real results, it will be another 3 to 5 years. You also have the Ranger SFA trial. Again, similar results sustained over a period of 3 years. Again, FPAC trial also says the same thing. So basically, what does it say? At the end of 3 years, depending on the type of trial, you get at least 75% patency at the end of 3 years, provided the lesion length is between 7.5 to 12. Best results are less than 7.5. 150 balloons are available, but again, if you go into the individual segments, if you have more than 15 centimeters, it does not stay open beyond 18 months. 50% patency. So this subgroup analysis, unless we come to forums like this and somebody puts their mind into the statistic, we start believing that 75-90% applies for all the patients. No, it applies for certain patients. Again, these are the references. I think all of us, a lot of youngsters over here, my age group people, we had this a cosmetic called Fair and Lovely. So we tried to apply it and think that, we could become fair and lovely. My hair turned white, my face didn't turn white. Okay, you do get the same thing, looks very good, but after a few years, nature wins and it's back to the same thing. Okay, so does it work? Of course it works. Do you need to be selective? You have to be selective. I always like to quote these kind of things where there is a lot of division among ourselves. It's like this: mutual fund investments are subject to market risk. Please read the offer documents. This comes in fast succession, but believe me, this is very, very important. You have all the data, but you also have the intellect not to believe a guy who comes and tries to sell you a drug who has not completed his degree, or he might have just completed a degree. He's a salesman, fine, listen. There are a lot of scientists who worked around it, but please look into our patient's condition, whether we are going to achieve the same kind of results what they achieve. Thank you, ladies and gentlemen.
Wonderful talk, Vivek. So I had one technical question. Most of these DEBs are 18-wire devices. at least me, I'm used to cross the SFAs and everything with 35 tarumos. So usually we cross it, then we advance the catheter, change the wire with the 18. Does that also increase the risk of distal embolization in DBs? Or
No,
what
like
is your practice?
No, where we have to change over to a overnight system, we do end up changing to the overnight system. Regarding distal embolization, I think adequate vessel preparation, if there is distal embolization happening in the initial vessel preparation itself, when you keep it for a longer time, that time itself it happens. I personally don't think it is the drug coating on the balloon which is causing distal embolization. Like I mentioned earlier, if the difference between the artery and the balloon is not adequately appropriated, and once you dilate, you have the drug washout. That is what with Jihad Mustafa told us when we went to Sydney. Okay, that is the drug which goes out and gets lodged in the capillaries, which causes this destruction. So appropriate sizing of the balloon is most important, and the way we do it, it's almost always, a guesswork. We will not be able to get the right kinds of, unless we spend that little extra half a minute and getting the right size. So vessel bed preparation is the most important thing, and do it right.
Sir, just a lot of trials were there, so they were all about the length of the lesion. But what about the procedure? If it is done luminally or subintimally, was there any change in outcome?
All of them were done transluminally. Yeah.
No subintimal or CTOs like
no.
long.
CTOs, yes, you try and go through through the so-called thrombotic segment in between, and you get in. Subintimally, you don't get good results with if you put a DEB out over there.
Excellent presentation, sir. Says the real world evidence is different from what the trial results show, or are they same?
No, it's not the same. It cannot be the same. It cannot be the same, and it's not the same. Okay? Because you look into the inclusion criteria. I think many of us did participate in many of the trials. If you look into it, they have very, very stringent criteria. If the total count is elevated, they will not even take your count for your patient, because you have an inflammatory response already going on inside the body, which sets it up for further failure. So they want highly controlled situations. And we should also try and opt, it shouldn't be that, we many a times, because of various considerations, we admit the patient today, tomorrow we post, in spite of having a lot of infection, in spite of inadequate control of the sugars, or maybe, the gangrene is so infective and spreading that we need to do both at the same time. But optimization is important, and if we think we can get that kind of results, no. With regard to our tibials, no. Our reintervention with DEBs are there, and we've got a pretty good follow-up. Almost 80% of our patients follow up for a period of 2 years with PVR, and we make sure that they come from whichever part they are. I think maybe in another year we should come out with some data, but believe me, it's not the same. In any procedure, it's not the same.
Hi. I had a couple of questions. First of all, which DCPs are you using and on a regular basis? That's one. Secondly, would you be comfortable in using a DCP for a long SFA lesion, de novo, in a claudicant? And third, have you ever experienced the dreaded slow flow phenomenon that is described due to distal embolization?
Okay, I'll take, our usage of DCB is not that very high. Let me be frank. You know the kind of practice that we do, where most of our DCBs, what we've used, end up in post-intervention phase. Already it's been done once, and second time we are doing it. Each one has a different kind of practice. I would like to use a DCB actually in a younger patient where I do not want to put a stent. Okay, if I want to keep it open for a little longer time, I would like to use a DCB. If I get a favorable result with a dilatation without flow limiting dissection, because that changes the whole scenario. Slow flow, no, but with tibial angioplasties, like I was mentioning earlier, we did see deterioration in the wound. And first 3 cases, there were coronary complications. We just could not explain it. And the wound deterioration also, we couldn't explain because he had a palpable pulse going all the way down into the foot. Wound which was red for quite some time after the procedure slowly started turning little grayish. We couldn't explain it. It's only much later when the other trials came that, okay, we could correlate, but, we always used to call, Shravan was the guy, I mean, he's a consultant now, so we always used to tell that, it's your bad luck.
So we are running short of time.
Okay. I just wanted to ask one question, if that's fine. I'm sorry. Most of these studies which were done and, all this technology has come from the heart into the lungs, into the legs. So most of the terms which were used for, so lumen loss, so late lumen loss, and freedom from TLR has come from the heart, where it's actually, important because you'll get inducible ischemia and these guys can have, so myocardial infarctions or they'll be symptomatic really soon. When it comes to the legs, what you are looking at and what people are trying to look at is wound healing. If you've achieved wound healing, are we, in a sense, sort of over treating our patients and saying, we want the SFA to be open for 4 years, 5 years. When, if you've achieved healing of wounds, it's very rare for that wound to occur again. And a lot of these studies don't actually address amputation-free survival, healing of wound, ulcer size, etc. So are we, just because it's there and it's out there, you can do it in the heart, are we just, extrapolating that to do to the
you
legs?
raised 2 very important points. Again, if you looked into Devinder's photo, the first coronary angioplasty and then after 18 years and the damn stent is still open. Can we, in our limited, I don't have too much of practice, 25 years of practice, I have not seen a single SFA stent open for more than 3 years. Not a single one. And I've seen quite a few bypasses open for decades, especially if we've used the vein. And if the second part of your question, if we achieve wound healing, whether we achieve wound healing or not, some of Amrish's talks earlier, it takes months, sometimes a year to heal a wound. So try and keep the blood flow going for a longer time.
So if I could rephrase and ask you, would you intervene if the wound has healed and the stent or the SFA is so not open then?
No, I would not
exactly.
intervene.
So,
no, not at all.
So if you
if
go the other way around,
wound healing,
yeah, exactly.
And he's symptom free, or even if he was walking 200 or 2 kilometers earlier, and now if he's walking for half a kilometer, I'm not talking about science. I'm not talking for others. In my patient, if he's achieved a good wound healing and it stays healed without the skin graft giving up at the edges, and he says, I'm able to walk for 500 meters and is 85 years, I wouldn't want to touch him. Just because there is a lesion, I wouldn't want to touch him.
But Pranay, on the same ground, if you have a wound which is improving and you find that suddenly it stops improving or deteriorates and there is restenosis, so in some situations you are forced to intervene.
You're forced to intervene, yeah. No, we do our PVR studies. They come at 1 month, 3 months, 6 months intervals. And we do notice, deterioration in the wound status with decrease in the PVR. Tibial vessel angioplasties, we need to be extremely aggressive with wound healing strategies, because at the end of 6 weeks to 3 months, your best angioplasty slowly starts coming down. So it's not just keeping the blood vessel open, you need to heal the wound. The patient doesn't know that he's got a blood vessel. He came to you because of a wound. Our interest is to heal the wound and prevent it from coming back again.
Just sorry to go on, but the reason I asked you the question on claudicant is because though the FDA has withdrawn its red flag, the MHRA in the UK still hasn't revised its guidelines. It's saying do not use DCBs on claudicants. Reserve it for CLTI. And since this is a conference on drug-eluting technologies, I would request the House to come up with some sort of a consensus, whether we are absolutely certain about safety, at least in Taxil coated balloons.
No, but again, if you go through the literature, majority of the patients are claudicants. That is both in Europe as well as in most of the European studies were either in Germany or in Belgium. Few of them in UK too, but majority of them came from US and Germany. Yeah, claudicants, you can say what you want to, but it's the physician who decides what needs to be done for the patient.
I think just quickly, since we're running short of time, just to answer, Satvik's query, just let's have a show of hand. How many of you actually treat a claudicant with an aggressive angioplasty using a DEB? How many of you in this crowd put your hand on your heart and say you treat claudicants with an angioplasty using a DEB?
I treat it with medicines. I hand on my heart. No.
So basically, I don't see anything. So, I mean, if we are to believe this crowd, which I think we should, none of them say they would at all treat a claudicant.
No, we do treat a claudicant with best medical therapy and modifications.
But not with a DEB.
Not.
Yeah. Yeah, exactly.
The thing is, we don't get such patients. Very few of our patients come with...
almost all our patients actually come with wounds which are not healing. So I think
or disabling
we should,
claudication.
our consensus should be on our type of practice rather than, look at European literature.
See, we all are vascular surgeons. And to begin with, earlier also in the practice and even now, we would probably think 100 times before offering a bypass for a claudicant. Because of the technology evolving so rapidly and angioplasty and stenting, a lot of people basically fall for this simpler and easier, including patients and the referring doctors. So as a vascular surgeons, what advice we gave to our patients as far as bypass was concerned, same we should think for doing an endovascular.
Exactly. Yeah, I think we should conclude with that because we're running short of time.
Thank you very much, sir.
Vivek, that was an excellent lecture. Yeah. Thank you.
The next,
Thank you,
we
Chairperson.
start with a case presentation. Dr. Krishna Chaitanya will speak on DEBs in femoropopliteal disease.
वीडियो प्ले नहीं होगा. Good afternoon. Thank you for giving us an opportunity to speak here. It's a wonderful gathering here. Nice discussions, and my talk is probably rightly timed at this point of time. We've had a lot of discussions and other things. The case we are dealing with is a highly calcified distal SFA and a P3 lesion. The vessel is extensively calcified all across from the iliacs. There is wall calcification, but there is a calcified occlusion of the distal SFA. And the age of this patient is 42 years, who also happens to be my classmate, female patient. Now, if we see, there is an occlusion, but below there is flimsy flow in the tibials and pedal vessels, but there are no occlusions below. if we see this, the success of an intervention in anything depends on true lumen recanalization. And when we zoom up, we see that this calcification plaque, and there is a thin line which is actually the compressed true lumen. It is very important to negotiate the wire across this particular true lumen to have a proper outcome for this intervention. Now, with repeated attempts, the lumen is so small that even an 014 wire, it is difficult to track an 014 wire. But with some efforts, it is possible when we realize what is the direction of the true lumen in this particular scenario. It's a very tight calcification. With some effort, it does cross that lesion. Right. Now subsequently there is a distal lesion there which again has some difficulties, but then we are able to cross it and park the wire in the common peroneal artery. But here our microcatheter does not track. So we start using a coronary balloon, a 1.5 mm NC coronary balloon to at least predilate so that our microcatheter tracks through. But even the coronary balloon doesn't track through that lesion. Then we increase the sheath to a 7 French sheath. This is an antegrade puncture. Now inside the 7 French sheath, we get a 6 French guiding catheter, and then we are able to push a coronary balloon and predilate it by 1.5 mm. Subsequently, we do a little bit of conjugacy. We want to use one balloon, so we take a 2.5 mm balloon and dilate the entire track. With the distal, there is another distal lesion there, entire track with a 2.5 mm balloon. Now after the initial dilatation, this is the scenario. There is some improvement in the flow, but hardly any luminal gain. So what would be the ideal thing here to do? I have no experience with IVL, and here the calcium is on one side, the other side wall is thin walled. It is normal. I do not know how an IVL would work, and the lumen gain is not much. Passing an IVL balloon might seem difficult in this scenario. So what would be the ideal solution here? Stent would not open. Definitely not. So what is your option, sir? No, sir. Sorry, I forgot. We don't treat claudicants. This patient had a paronychia. The toenail was excised. She developed an ischemic ulcer there. The bigger balloon? Bigger balloon and then... okay. Because you're already committed, your costing is already... See sir, I want to, if I use a bigger balloon, I might cause dissections in the adjacent arteries. Now that is an area which I would not want to stent. You see, one is, are you in intraluminal or it is subaluminal? It is intraluminal, sir. You checked it out? Yes, it is intraluminal. But then use an atherectomy device. Okay. Okay, and that is what we did. I am happy I am in consensus now. So we did the stealth atherectomy. So we went through initial 2 passes with the slow speed, medium speed. And this is after the first 2 passes, there was some amount of luminal gain. Now after the 3rd pass, there was significant luminal gain across those lesions. Now this is an area where we do not like to stent because patient is young. We might have to do a bypass in the future below knee, one of the tibial arteries or what. We don't want to stent that area. So we decided to use a drug-coated balloon in this territory. It's a 5 into 150 millimeters drug-coated balloon. The drug-coated balloon we used, we have used both Medtronic's Impact as well as Lutonix. Lutonix is preferred in calcified lesions. Impact is preferred in atherosclerotic lesions. The reason is simple. Urea is more lipophilic, the excipient. It is more absorbed and retained in the lipid-rich atherosclerotic disease. While sorbitol, which is the excipient in Lutonix, has better affinity for calcium hydroxyapatite and better retained in calcified lesions. So this is the, after drug-coated balloon, this is the final outcome of the same lesion. And below knee, whatever was flimsy filled better. That blush is because of NTG we gave because there were some vessel spasm, but otherwise there was nothing. So for us, yes, there have been embolization. The same case there has been embolization. It is there on the laptop, but for some reason I cannot zoom it. That embolization right falls where I have 12 days trial period. I cannot zoom it and capture it. We can clearly flow some free floating particles in the arteries. There is initially cold feet. The wound seems to worsen for the first week, but those similar situations have happened with POBA also. Initially, when there is reperfusion, the wounds, they are more prone for infections. There is edema. There is always worsening of the wounds. But none of the wounds have led to adverse outcomes. Wherever the salvageable wound is there, it has been salvageable. Wherever we have been able to amputate the toes for primary reasons, we have been able to amputate the toes and close it without any excess delay in the recovery period. So, of course, we have to embrace change because that is the only thing that is constant. And the first thing towards change is awareness. And the second step is acceptance. Thank you so much.
Yeah, so I have two very quick questions. One is, how do you know for sure that you are in the true lumen? Very often we get this gut feeling that is true to false to, true to subintimal to true.
Yeah.
Unless you have an IVUS, how can you be so sure? I mean, a practical
in
question.
this case, we can't pass an IVUS, sir. Number one. Two.
No, but generally.
Yeah, we are able to rotate the wire completely.
But it can rotate even if it's true and false and true.
No, sir. This is only after that lesion is a short lesion. So if you...
I mean, for those who have not used the atherectomy devices, you have to be dead sure that you are in the true lumen for you to be using it. So how can you be so sure?
I cross all my wires of SFA and ultrasound guidance, everything. Sir. So, honest, transcutaneous ultrasound is an amazing technology, and I think still, as a vascular surgeon, we use much less. That, I hardly see people using, transcutaneous of SFA crossing of the lesions, ultrasound guided. It really makes a hell lot of difference because you know exactly where you are going. And you have to use a transverse and a longitudinal sections both. And once you cross a wire like this on a DSA, it's impossible to know what you are asking. But later on you may be able to know.
Sir, number one, this is a DSA copied on a freeware plus projected on a OHP screen. If you actually see it on the monitor in the cath lab, you are easily able to make out that calcium which is sitting like a pimple inside the vessel. Two, now I have put only relevant sections of the study where after passing the wire, we are able to completely rotate the wire and we are able to move it freely in the lumen. We cannot even pass a 1.5 mm balloon across that at that juncture. And two, that is the reason I have zoomed it up and shown that is the only part where there is actually a true lumen filling. And had we been subintimal, it's a calcified lesion, so going subintimal is less likely, but had we been subintimal, there would have been dissections
No,
there.
my contention was sometimes you go true lumen, subintimal, true lumen again. And even after that, your wire moves freely. So that is my contention.
There was no loop, Sekhar. There was no loop of the wire. It was just straight.
Right. So that's what I wanted to know. Yeah. Secondly, using jet stream, what is your thought on using a filter? Because it's generally advisable.
We used stealth, not jet stream, sir.
Use a stealth.
Yeah.
Okay. Because in jet stream, I think.
Stealth? No. We had a CT done. CT showed a glow of calcium. We had a backup plan, but we realized it is more tougher. It was more suitable for this case.
So I think this is a very important learning point. If you've seen a nasty CT and you think you might need it, ask for the hardware before. Otherwise, the way he's stuck here, you're not going to get an atherectomy device turning up in your cath lab in half an hour. No, you have to be prepared.
We usually don't prefer CT in calcified disease, sir. She was 42. my classmate, I got carried away. But when we saw the CT, we realized it is highly calcified. So we had a backup, but then this was the situation.
Robbie,
The moment like you envisage a situation that you will have to use some atherectomy device, everything changes from expenses to, and if you have not explained it and all, and some of the devices you really need a team of people because they come with a machine and all. So unless you have it all in, it's really.
so it has to become part of our practice.
You're right, yeah.
Some point of time we'll have to imbibe this.
When it becomes more affordable, it will become. Krishna, since this is a kind of an significantly eccentric, would you have preferred to use Turbohawk rather than what you use? Because since you're eccentric, I thought that would be more ideal for doing that.
Passing a turbo through that would be difficult, sir.
No, see, what would be difficult? See, you already got a balloon and you have done plastic.
Yes,
and there
I
was a
didn't want to use a bigger balloon.
No, 1 second. I'm not saying use a bigger balloon. What I'm saying is, if you are using a Turbohawk, then normally for all these, we tend to use a filter distally because the risk of distal embolization is there. And since it's an eccentric plaque, and if you have already done plasty and you're in a position to pass your filter down, since it's an eccentric plaque, a Turbohawk might have been a much better option to shave that off and reduce the chance of other issues.
Yeah, maybe it is different device for this achieve the same goal, sir. But we did not pass a filter down.
But this device, which is there, is actually very useful for eccentric ones because the device goes absolutely like this.
So how will it work for eccentric?
It works, no,
it will
because
be better for concentric, no?
No, it works for both. That's the advantage of this device.
Yes, sir.
Thank you very much.
Krishna, any reason why you think heavily calcified?
Sorry,
Age
sir?
of 40?
She's a diabetic, sir. She's a diabetic. She has diabetic retinopathy and.
CKD also?
No CKD yet. I didn't ask her, but yes, long-standing diabetic. Sorry, sir. On insulin.
So I have a pharmacological question. There are some studies where they use in such heavy calcified peripheral arteries or everywhere in the body in diabetics. Is there a role of that tablet called Canadion or anybody has any experience with it?
I think it's a preventive one than curative one, sir. K2. It prevents vascular calcification. Therapeutic also. It reduces vascular calcification, sir.
Yes, it pulls the calcium out of the vessel.
So we are running short of time. Thank you very much, sir. We come to the next set of chairpersons. Thank you, sirs. I would like to call Dr. Lakshmidharan, Dr. Ashutosh Ahir, and Dr. Bhushan Shinde to kindly come to the first seat here. And I would like to invite Dr. Robbie George, sir. We are postponing the industry talks just to the next session, just because we have to have tea after this, after 2 more talks. So I would like to invite Dr. Robbie George, sir, for his talk on DB's post-atherectomy, marriage made in heaven.
I'd given you the pen drive.
The OI pen drive.
The Vessomag team, and a great idea, great meeting, enjoying it thoroughly so far. So atherectomy and DB marriage made in heaven. I think Casey just proved that this marriage has been made in heaven, and let's see how long these marriages last. So, like all marriages, it's not all made in heaven. Some of it requires some therapy to happen alongside it. So for the younger people in the audience, so the limitations of DB is that yes, it's just a balloon by itself, and the purpose of that balloon is to try and achieve luminal gain, and the purpose of drug on it is to try and maintain long-term patency. But you still deal with the problems of elastic recoil, dissection, acute closure, and the fact that a balloon does not work very well in heavily calcified lesions, and that's the whole principle of this, which is where you marry in the other technology of trying to achieve luminal gain. And the principle of atherectomy is that you're using a sharp knife or a hard knife against an area which has got soft tissue and hard tissue. The soft tissue doesn't get sliced, the hard tissue gets cut through. That's the essential principle of atherectomy as to how it works. And multiple types of atherectomy. In fact, just now when Casey was saying he used the stealth device, I didn't know what the stealth device was. I had to actually Google it to see what bloody kind of thing it is. There are so many different devices, it's confusing. So let's be honest about this. I'm going to ask Vivek difficult questions as president of VSI on all of these later on. But essentially, you've got these different kinds of atherectomies, the directional ones, the rotational, the orbital, and the laser ones. And that's the broad groups. Now these, again, classifications of these, and these had been shown before, so I'm going to just run through this atherectomy bit a bit quickly, but I think it's just good to know what you're dealing with over here. So Medtronic has got this Hawk series, the Silver Hawk, Turbo Hawk, and the Hawk 1, and the different generations of it. So the Silver Hawk is essentially a directional cutter for soft to mild plaque while it's actively retrieving whatever you're cutting out. The Turbo Hawk has got a high efficiency model and a lower efficiency model, again for mild to moderately calcified lesions, but you need to use a filter. And remember, this filter will keep appearing when you look at atherectomy because you require embolic protection device. The Hawk 1 is a directional one, so good for eccentric plaques like Vijay was saying earlier. And remember, none of these devices are actually licensed for use in the iliac or the renal or the aorta. So that's, you don't want to be sticking these atherectomy devices in there and landing into trouble. So these are all for SFA and below. The rotational atherectomy is essentially like a drill bit that you're shoving into the vessel and getting it to spin and drill a hole through that. The BD, so this is the Boston rotablator, and essentially all of them got a diamond-tipped burr head which kind of drills through this stuff. And you can imagine when you're drilling through things, what's happening, you're sending a shower of material lower down, which you need to keep aspirating out or filtering off. The Rotarex is the BD one, which actually has got an interesting story behind it, because the guy who manufactured this device, who actually created it, was an industrial engineer who manufactures massive connectors for ships' plumbing. So he does specialized manufacturing of very high-end plumbing devices. He developed PAD. He went to the University of Zurich, where he ended up getting his angioplasty done. Zurich is the same place where the first coronary angioplasty was done, which is where I heard the story about Grunzig being chased out of the university. So he went there, he had an angioplasty, and he said, this is a terrible procedure. You left behind all my disease, and I haven't had any good result from it. So the vascular surgeon was his friend. He said, this is the best we've got. You are an engineer. Why don't you come up with something? So he then sold off his company, opened up another company, which was Straub Medical. So Straub was the guy who did this, put people on the job to try and create this device that actually looks at how you will do an atherectomy. So it's based off principles of shipping and plumbing. So they got this very high-speed screw that cuts through it and then sucks out stuff. And the advantage is you can use it for both, for fresh thrombus, and you can use it for subacute thrombus. It's not that great for calcified. So for in-stent restenosis, for using in grafts and things like that, it works well. This is the Phoenix, the Philips one, which is again supposed to be kind of a hybrid system, rotational, involves a directional and a rotational device. The Jetstream from Boston, which has got, the advantage is it's got two kinds, it's got a blade up and a blade down, which allows you to modify the degree of device luminal gain you want to achieve with that. The orbital atherectomy, which is the stealth device that Casey just showed, which again is good, especially for low profile. And you've got the laser atherectomy, which we do not have, but it runs very slow, but it might be something actually quite attractive. So this is atherectomy, which we've not discussed so far. So what are the challenges with atherectomy? One is embolization. So you either require very active aspiration of whatever is going on, or you want a filter. Restenosis does happen despite immediate plaque removal. This disease is going to want to come back, and by and large, most of us are going to end up using atherectomy in patients who have bad disease. So these are the ones who are bad protoplasm, who are likely to come back with aggressive disease. When you cause so much trauma to a vessel wall, you're going to initiate a massive inflammatory response, which will come back to bite you later on. The vessel damage itself can cause trauma and a dissection or a perforation. And you are going to require concomitant long-term therapy. So this is where the DART philosophy came up. Let's use a drug-coated balloon associated with an atherectomy and leave no foreign body behind, because leaving a stent behind induces constant stress on the vessel wall and increased chances of neointimal hyperplasia. The theoretical benefits are plaque debulking and modification to maximize acute luminal gain, remove the calcium barrier, which allows the drug to move inside nicely when you use a drug-coated balloon, and you minimize the need for stenting. That's the theory of it. When you remove the calcium, you are actually able to use a lower pressure balloon when you do your angioplasty. So you don't have to use high pressure and cause high pressure barotrauma as well. And because you remove the calcium, the drug that you're delivering is able to go uniformly. Remember, everybody was talking about if you've got an eccentric plaque, your drug does not reach everywhere, you embolize more. So when you debulk and you've got a clean surface, your drug-coated balloon is likely to be more effective. So that's the theory of it. So this was the first study, which was a definitive AR study, which was just a subgroup of a larger definitive study, which came out in 2012. Now what this showed is that directional atherectomy plus DCB was effective and safe, but the study was not powered to show any significant difference between the two methods, and trend to potentially better outcomes in severely calcified, longer than 10 centimeter lesions and CTOs. And this is where Vivek will get very happy, because I'm going to show a lot of trials. All right? So ideal trial 2015. And again, all of these are small numbers. All these trials are industry supported. And if you look at the ideal trial 2015, DB atherectomy 12 month, 80% versus 70% for standard balloon. Restenosis rates, DB 21.2 versus non-DB 31. TLR lesions are different. Pacifier study 2016, atherectomy plus DCB. Restenosis at 12 months, 21% versus 45%. Freedom from TLR, 90% versus 76%. East PAD trial 2020, similar kind of results. Why should sirolimus be left far behind if you're looking at paclitaxel? So let's do a LEAP study also, which again, 100 patients, not large numbers when you're going to look for differences. Again, shows DB with atherectomy slightly better than atherectomy with plain balloon. How about if you go into long infrapopliteal lesions, an RCT showing no significant benefit for atherectomy plus DCB in treatment of infrapopliteal arteries, which is the one area where we might have been really keen to use something of this sort. So if you look at a summary of the trials, across multiple studies, atherectomy used with DEB helps to reduce the restenosis rates compared to atherectomy alone. There is a consistent improvement, not very great, but there is when you combine atherectomy and DB. So task 2 recommendation is consider use of DEB for complex fempop lesions, especially following atherectomy or in high-risk patients. So there is reasonable societal evidence for this. But using DCB does not really impact your provisional stenting rates. Your provisional stenting rates with DCB is likely to remain about the same, so you don't really get a huge benefit from that. So who are your candidates where you would want to consider DCB and atherectomy is? So ideal candidate, somebody with severely calcified fempop lesions, somebody with in-stent restenosis. But like Vivek was saying, just an angioplasty is not going to be enough. You are going to require an atherectomy device to remove all that neointimal hyperplasia. And then to prevent it coming back, you would look at using a DCB. Complex multi-segment long lesions, high-risk patients. If you've got bad quality vessels, you're not going to get a good quality outcome regardless, but atherectomy probably is going to be your best choice of that. And of course, contraindications for drugs. The other contraindication is, of course, the big bugbear in India. You use a DCB and you combine it with atherectomy, your cost is really going to shoot up, and really speaking, not everyone can afford that. In the longer term, you are potentially reducing reintervention costs, Cost effectiveness, my personal bugbear, all our cost effectiveness studies are from the Western world, and trying to apply a cost effectiveness analysis from the United States of America to the United States of Bangalore is not going to work. So please do not talk cost effectiveness unless you've done it in your own country. So is atherectomy and DCB a marriage made in heaven? Maybe, but even atherosclerosis and calcium were also manufactured in heaven, so you don't know what you're going to do with all of them. So bottom line, if you are going to do an atherectomy, you really should look at combining it with a DB if you want to optimize the results of that. But it is not the holy grail of everything. Thank you.
Hi. Absolutely fantastic. Atherectomy plus DAB. But when you look into the DAB indications, even in the task guidelines, and they say use the DAB for the complex lesions, in bracket is written calcified lesions. And when we look into the physiology and we say that the calcium hates DAB balloons, it totally contradicts what is written in the guidelines, and it's totally contradicts what does the papers shows.
No, very, very true. I think, in a sense, a lot of this is a reflection of the fact that there is bad pathology, for which we don't really have a good solution yet. And we are still, in a sense, looking for that. So is it a stent that is the best, but the trade-off is, recurrent occlusions and problems with that, or is it an atherectomy with a DCB, or is it a POVA? So we're still looking for solutions. I would actually be interested to see IVL with DB, because the way IVL just fractures and softens up the calcium, do you get better penetration of the DB with IVL? I don't know, but it's just something to think about.
Robbie, nice talk. I read through some papers. All the papers say that most patients treated were claudicants, not CLI. I couldn't hardly find any paper where they use DEBs in CLI patients. We are talking about Rutherford 6 and 5. All this big data has got chunk of patients in Rutherford 2 and 3. In 3 and 4 basically. So did you come across any paper where they actually use DEBs in CLI patients?
So the data is actually, like I said, all this data is 100 patients, 110 patients, all industry-driven trials. So there is very little evidence. We were talking about this earlier also. In CLTI, we are all concerned about distal embolization, especially somebody with diffuse infrapopliteal disease. So in that patient group, I am wary about using atherectomy, and I'm wary about using DB. My atherectomy experience is in single-digit figures. We don't use too much atherectomy. But the question is sometimes what options do you have? It's not that we have a wealth of alternative great options. So in those situations, this is a viable alternative to think of in your choices over there. I don't think it is the be-all and end-all of anything. But if you've got bad SFA disease, so somebody with CLTI, a bad heavily calcified SFA, distal disease, most probably I would tend towards using an SFA stent, achieve the maximum luminal gain that you need to achieve for those 6 months or 10 months before it occludes, and in that time you hope your vessel heals up. That's how I would tend to do this group.
Generally, I feel the evidence is very much minimal for use of DEBs in CLTI. We are trying to extrapolate the results of claudicants to CLTI. It's actually not, in the real world, that cannot happen. The discussion, we are focusing on CLTI, they are focusing on claudicants.
And like we said, you see, our aims are very different. Our aim is get the wound healed, get the patient out of CLTI. Their aim is long-term patency and claudication treatment. So our goalposts are different. Yeah. And it's also a matter of costing. In the West, a DB or a plain balloon costs almost the same. Over here, it's a difference of 3x between the two.
Is very well pointed out, sir. All the trials on atherectomy, they are hardly 100, 150 patients, but every atherectomy device is FDA approved.
So I will refer you. There was a paper that came out, I think, in the Annals or the JVS that talked about the link between physician reimbursement and the use of atherectomy in the US. And certain well-known names from the vascular community were also involved, and their name came up very badly. It's like literally there's a 100% atherectomy rate. because the kind of payout that the US physician gets for an atherectomy is about 10x what they get for an angioplasty. So there's a lot of financial incentivization in the US system for use of atherectomy. I've seen this happening live in front of us. A lesion which any of us in this audience would have done a simple POBA for, they opened 3 balloons and 2 atherectomy devices over there. And it's just, it's a different story there.
In fact, atherectomy is overburdened.
Ganesh,
Absolutely
money
right.
was recovered from him. The amount, what
Yeah.
you were saying about Jihad Mustafa, money was recovered by the government.
And there were a number of patients who underwent atherectomies and eventually landed up with amputations, patients who were asymptomatic with incidentally discovered SFA lesions. So the atherectomy space, the data is very industry driven, and a lot of the data that is produced is by physicians also who have been for multiple reasons have been involved in that.
Right. Can I ask everybody on the who is the real enemy? Calcium, thrombus, or as Vivek said, neointimal hyperplasia?
All three. All three.
Who is the worst?
You don't have a choice to pick.
It depends on the day of the week.
You know, Robbie, it's very interesting that in this definitive and all these trials, the best results are for the short lesions and non-calcified.
You see, it is the pathology that determines the outcome. What else we are doing honestly makes a limited amount of difference there. Sorry, Amrish.
We've used Rotarex quite extensively, and it's also sold as a thromboatherectomy device rather than an atherectomy device. And the story that you recounted was fascinating, but what's even more fascinating is that it's got an Archimedes spiral, which is just moving, and it's sucking without applying any suction.
Yeah.
And it's perhaps the only device where they are not advocating a filter, other than orbital atherectomy. So even for Dr. Chaitanya, because Stealth is an orbital atherectomy device, I was curious why a filter was used in that case, because apparently it's sanding the... Oh, you didn't, right? Okay, right.
Yeah.
Because it's sanding the plaque,
Yeah.
and as a result of the sanding, the particles that are produced are smaller than the red blood corpuscles. So
Yeah, so the Rotarex works on that Archimedes screw. The principle is running at something like 20,000 revolutions per minute. So it's creating a massive suction there, which is supposed to suck out all of that, which is why it doesn't work very well with calcium. It works well with acute and subacute kind of thrombus, or the stuff that reforms in a graft or a bypass.
Very true. But Robbie, having said that, all of us putting longer stents, real life, let's say real world data, you have longer stent lesions, long lesions, and you have a choice to put a long stent, let's say 20 centimeter or 15 centimeter above, versus DAB with some adjuvant therapy preparations. What would be your call?
So if I've got a patient with CLTI, where there's got major tissue loss, I would go for a stent. And that's purely because I want to bail the patient out of losing the leg. If you're looking at somebody who is an elderly patient, who is a claudicant, which we don't normally would do, but someone who says I can walk 50 meters and I can't do more than that, and he's not well enough for anything else, that kind of situation I would prefer to use a DB. But certainly the picture you get after you put a stent of the luminal gain versus the picture you get after you get a DB is worlds apart. The stent picture looks like this beautiful highway. The DB picture, not so nice.
But what when they come back to you in no time?
Yeah. So I send them to Vijay Thakur and Baroda.
No.
So we cannot put a filter in orbital atherectomy, sir, because one, it has the rotations. It also heats up. It needs a lubricant, and the wire we are using in that is a bare wire, a stainless steel bare wire called Viper wire, which I think any other coating will wear off and embolize by itself. So we cannot use a filter in orbital atherectomy. No. The size of the particles are bigger. Don't believe the industry. They are bigger, but they are at least few of the particles, especially in such cases, are bigger. So not less, because we can visualize them in the angiogram. When you mag and see, there are a few like flimsy thrombi which are floating in the vessel, which were not there prior to it. Now, difficult to pinpoint if it was due to the atherectomy itself or due to the plasty of the lesion or due to whatever balloon, drug-coated balloon we are using.
but there are bigger particles.
So I think I'm the only person standing between one case and the tea break. So I'll just quickly finish it off. I'll be presenting case number 2, which is on rotational atherectomy with paclitaxel. So this is a 54-year-old male who came in with a right lower limb non-healing grade toe wound with paronychia since 3 months with rest pain. Now this patient had a history of atrial fibrillation and he was diagnosed 5 years back, and he was on apixaban 5 milligram twice a day since then. He's a hypertensive patient since 10 years, and he had a 2 by 2 centimeter wound on the medial aspect of the great toe with partial nail avulsion. The patient on examination had absent popliteal and ankle pulses on both limbs, and both lower limb Doppler showed a distal SFA popliteal lesion with poor blood flow below the knee. Now, this patient came to me. I treated him medically for 3 weeks, and there was pain with no improvement of the wound. So whenever there's an absent popliteal pulse, I normally do a CT angio. So the CT angio gave a very peculiar sort of a report. It gave as a long segment irregular thrombi, which was seen in bilateral popliteal arteries and left distal superficial femoral artery, and causing variable partial to severe luminal narrowing. And it was less on the right side, more on the left side. However, the wound was there on the right side, and there was no wound on the left. Now, looking at this report and looking at the film, I called up I told the patient that you might require a stent or a bypass if it does not come out. Looks like a thrombus. But the patient had already undergone an angio before, and there they found that the wire could not go down on the left side. So my plan was, number one, DSA and proceed. I did a D-dimer just to rule out any acute event, which was quite nominal. I thought I'll treat only the right leg for now, and I'll go for the left leg later. And if, for example, I go in, I see acute clot and lies, do an atherectomy if chronic, and as there were popliteal lesions, and I didn't want to stent the popliteal artery. And if, for example, I'm using an atherectomy device, I treat both the legs simultaneously. Now, I did an angio for the right leg. There was quite good flow, good, nice vessels. But as I went down, there was a plaque, which was quite bad, with a lot of, the old thrombus which had laminated and formed in that area. So I called up Bard. I asked them whether I could use their Rotarex or not. But they were not very clear with the indication of the device. So then I called up, I had no other option. I thought I'll call up Boston and I'll ask for Jetstream. So I got a Jetstream done. So in this case, I saw the Belloni runoff as well. The Belloni runoff was very slow in nature through that plaque. And I still gave a little bit of Actylase, 4 milligram of Actylase in this patient. And the top part basically cleared up a bit. I put my wire across this lesion. The wire went through the true lumen, through all the old laminated thrombus, plaque, the lesions which were there in that area. But I could get into the through lumen all the way down. You can see through the wire movement as well. And I used the Jetstream atherectomy device. Now, I had been told that do the top first and then go below. I was scared to use a filter because I did not have a wire which was meaning it clubbed with the device, and I was fearing, the coating of the wire to basically get delaminated and the coating going down. Gave me a good result per se. I could get a good outcome. The atherectomy device went well from top to bottom. Post atherectomy, this was the result. Okay, I did a balloon at that place. I used the drug-coated balloon of Boston, which was Ranger, paclitaxel coated. And post DEB, it was a larger vessel of 5 mm. It was quite a decent result. The Belloni runoff was anterior tibial, posterior tibial, and peroneal, which I could see quite well. And the peroneal, although they were poor, the ATA and PTA was dominant, but there was some amount of thrombus migration in the distal PTA, where you could see the DPA going down, but little bit of thrombus there, spasm there. I still gave some Actylase, and now this patient had a palpable DPA on table. The PTA was biphasic, Now the problem was that the cost of the atherectomy was quite a bit. And the patient on table said, I want the left leg too. I get severe pain in the left leg when I walk, so please do the left leg. So I took a consent. Till the time the lactylase was given on the right side, I went with the left. The left was even scarier. The lesions were quite bad. And in such cases, normally we tend to do a bypass. I told the patient that I think a bypass would be better. But then because the machine was new and there was an intention to use it on this side as well. So I crossed it, true lumen to true lumen, took some time to cross. There were a lot of outpouchings in the vessel, but I could get some access through the true lumen. As you can see here, the wire initially went into those areas which were filling, meaning the outpouchings, and I could get access into the main lumen below. Okay, and the wire goes across. The ankle runoff per se was more anterior tibial artery, dorsalis pedis artery dominant. The peroneal and PTA was not there. Probably he must have embolized before as well. Use the jet stream first from top to bottom in the minimal mode and then on the maximum mode. And after the first pass, the result just changed. The bad lesion started looking quite good. And did the popliteal atherectomy as well. I would have put a stent over here. But the outcomes post a DEB, again a Ranger balloon was used. Post a 5 mm plasty, the post atherectomy outcomes were actually quite pleasing. There was good runoff, and in this case, there was an ATA runoff, and there was a palpable DPA at the end. Now, post-procedure doubts I had, was it a right choice for an atherectomy with DEB? It was a joint, and that is what promoted me to do it. Filter usage, I went through the data previously, and per se it has shown very good benefits, but there was no real consensus about using it in atherectomy in all the papers. And long-term patency, we'll just have to wait and watch. I think the main problem which we face is that we use expensive devices and think that this will save us the day, but it also costs a bomb. And if something goes wrong, that costs us dearly as well. I'm talking about embolization. Thank you very much. I had actually, the problem was because I was doing a procedure and I would have made another puncture. That is why I just gave some bolus actylase inside and kept it. That's all. Ideally, I would have given 8 milligram bolus. Femoral, antegrade.
Dr. Anirudh, just a thought. Young patient, bilateral, similar pattern of popliteal disease. So hopefully the other causes were ruled out.
Yes,
Local causes were ruled out.
Yes, they were ruled out. The arteries above and below
Because
were quite
the lesion, the arteries above look pristine. Both similar pattern of disease, both similar location with distal embolization.
We had done we had the CT which was done. I had seen the cross sections as well. There was no other external forces which were compressing on the artery. No, no embolism.
Depends on the kind of.
Oh, I'm sorry. The
coronary,
yes. He was a 50-year-old patient. Coronaries were okay, but he was a case of atrial fibrillation. That is where he had embolized. About 5 years back, he had embolized down.
54 is a bit late for entrapment. What about cystic adventitial disease?
No, sir. I'm not saying any extentic.
Yeah. Anirudh, normally when you use a DEP, the standard way of doing it is you pre-dilate first.
Correct.
And then you go and put the balloon. But your presentation, I thought you said that you directly...
Sir, post-atherectomy, we can directly go in and use the DEB because that gives better drug delivery.
See, the problem is what, no, that your post-atherectomy, you didn't have a very good lumen throughout. So there were areas of stenosis, there are areas there. So considering that, my preference would have been to use a standard balloon first, prepare the wall and then use that.
Okay.
going by the nature of disease, it must be a chronic thrombotic disease. Artery per se were never diseased. It has traveled from cardiac. So what's the logic treating blood vessel using DEB?
No, so basically as I followed the protocols. I had to do an atherectomy and post-atherectomy to reduce the disease.
See,
I understand.
Yeah,
I understand.
atheroma
It is
was
not the
never
vessel
there.
which is diseased.
Yeah,
Correct.
exactly. So,
Correct.
exactly.
No. Basically, it's a misdiagnosis, guys.
It's a thromboembolic.
Yeah. Exactly.
No, it's a misdiagnosis. At that point, he may not have understood it's an embolic. If he would have diagnosed it's an embolic, he would not have done all. No, I
No,
know,
sir.
but sometimes you don't understand. Happens, sometimes you miss it, and this can happen. But if you think it's an embolic, then you will not use drug-coated balloons and atherectomy devices.
But the bad guy says can't use it because
Yes.
right case to use Rotarex.
I actually called up the BART person. The first call went to him. He said the indications are not very clear. And it was not an acute thrombotic event. It was rather an embolic event. This guy had embolized previously. It must have gone and attached in that area because of the bifurcation and the flow dynamics. And over a period of time, that lesion caused some embolic shower, and that caused the wound per se. Yes.
And it's good you didn't do the ballooning, because if you do in all these thrombosis, even they are chronic, and even if you open them, or if you do an open surgery and do an thrombus, you see the type of thrombus they have. If you do the ballooning, they still embolize.
They'll still embolize, correct.
I know, luckily, because after thrombectomy. Because what happens is when you do an atherectomy in these cases, the soft part of that goes off. That gets sucked up. And yeah, and then the lysis also helped him.
4 milligram cannot help like this.
Imran is there.
We have the
4
BART
and
guy, so
2.6.
what is
I
the
called
take
him,
on
yeah. So the problem is, I was scared because the machine spins. Many a times I have seen complications where the wire cuts away or cuts through. The wire gets heated up. In rota ablation as well. So many. Correct. So for that, sir, the vessel was blocked from top to bottom. I went from top first. I tried to go and core as much as possible and suck as much as possible so that embolization does not occur. But I agree, sir. But the only thing is I don't know the machine, the recommendations, what they are.
What does the BART guy say?
BART guy is going out of the room now.
No. BART guys, would you recommend a Rotarex in this? Having seen the whole case, what would you recommend for those who have not yet used it or whatever?
That you go slow. If there is a calcified lesion, definitely you can't use Rotarex. You can use if it's a plaque, but if it's a calcified, you can't use. But the thrombus is there. Even if it's a chronic, you can use it without any issue.
Correct me if I'm wrong. This AN embolization was 5 years ago.
5 years ago.
Why now the clot is not going to be soft?
Yes, it will be hard.
It will be secondarily calcified.
Yes.
Hardened, and that's probably the reason why
Yes.
Rotarex would not have worked for if it was calcified. Then you require something to deal with the calcium.
It was a mixed clot basically. It had become, it was a mixed plaque currently. Yeah. Yeah.
One question.
I will tell you, sir. The wire's coating had got eroded. I had to use a new one. That was a Asahi Astato, what I had used. They don't have. They use Asahi Astato.
One final question. How many of us honestly would have used stent first option or atherectomy first option? Honest opinion. Seeing that angiogram, atherectomy first option, stent first option.
Sir, before atherectomy, I would have also used stent.
That's all I want.
Thank you. We break for tea. Everyone, kindly join us on second floor, please. 15 minutes. 1-5. Robbie, sir. ये दोनों एक ही चला गया All yours.
चल रहा है या तो सुनो बहुत ज्यादा टाइट हो गया ना ब्रेकफास्ट कर लेने ब्रेकफास्ट पे मीन्स यहाँ 9 बजे से है ना 8 बजे अपन 8 बजे यहाँ 7:30 बजे आ जाते हैं
Hello. Sir, could you connect your link? Okay, I just checked it. Post has joined, you have to let him in.
चाय पे चर्चा मोदी जी में बिहार
सर आ ही नहीं रहा उनका आ ही नहीं रहा है
कवर कर रहा है ना
सर उनको लिंक पे क्लिक करना पड़ेगा उनकी सेवा नहीं है दूसरे का है
बोला वो सबको एक एक को पकड़ के ला रही है नीचे चलो यार इसको डिस्प्ले करा यार
वहाँ पे परमिसेबल दूसरे का आ रहा है हाँ मगर सर उन्होंने लिंक पे वापस उनको क्लिक करने बोल दीजिए क्योंकि उनको ना यहाँ पे सिर्फ हम लोग परमिसेबल दे सकते हैं
हाँ नहीं वही बोल रहा हूँ
लिंक पे क्लिक नहीं करने तो हम कुछ नहीं कर सकते
हाँ नहीं मैं वो देखना बाकी है सब बड़ी बड़ी बातें
कितना बाकी है मेरे को आगे का प्रोग्राम
ये क्या हो रहा है देखो ना यार पिरामिड का क्या हो रहा है
मैंने उनको साइन आउट करके साइन इन करने बोला है आप लोग देखो ज्वाइन हो रहा है
वहाँ पे उनका आ ही नहीं रहा
वंदे भारत विषय के बीच में कभी भी
Hi, can you hear me?
Mayur with us. Sir, the stage is all yours.
Thank you. All right. Afternoon, everyone. Thanks for joining. I'll just, can I please have a share screen? Thanks. Thank you. All right. So thank you very much to the organizers for inviting me to speak today. And my topic is in-stent restenosis, whether the options atherectomy is better, DCB is better, or if we have to use both. Here are my disclosures. The thing to understand with is there an echo?
We can hear you.
Is there an echo? I'm getting an echo.
No, it's okay. You can go ahead.
It's okay. Thank you. All right. So, in-stent comes to treating it. So the vessel response to stenting differs depending on the stent compared to balloon angioplasty. Certainly, but also differs between stents depending on the length of stent, the design of the stent, whether it's open or closed cell, the composition of the stent. So the old stents were all stainless steel. These days, most stents are nickel titanium alloy, and also technical factors with relation to the implantation. And this is where really stenting from healthy artery to healthy artery comes into it. Compared to balloon angioplasty, elastic recoil and negative remodeling as an early response are both eliminated. But there is still significant trauma to the vessel wall because you implant a stent, the struts have outward radial force, the struts themselves are traumatic, so the moment you get endothelial damage, you're going to get early thrombus formation. The body's response to that is a thing called intimal hyperplasia. So you get vascular smooth muscle cells migrating from the media and they replace that traumatized intima through the inflammatory response. That ends up with neointimal formation within 2 weeks generally, and the entire process is generally finished by 6 weeks. And the neointimal lesion itself is quite different to the atherosclerotic lesion, both macroscopically as well as on a molecular level. The other thing to note is that in-stent restenosis affects 30 to 40% of patients within 2 years of stent implantation, particularly in the femoral popliteal segment. So it's a common problem. We do have strategies medically to try and address it, but even with that, it still affects a substantial number of people. This slide is basically just showing the like a schematic of what we discussed with regards to the basic pathology of it. So you've got all these smooth muscle cells sitting in the medial layer. There's trauma from the stent. In the interstices, you get the thrombus formation and a platelet plug. And then as a result, to sort of cover that over, you end up with cytokine release and this neointima formed. And the restenotic lesion occurs at that point in time. It generally occurs more commonly at the edges of the stents because you get more growth in from the normal non-stented artery as well. There are two separate classification systems for in-stent restenosis. They're pretty similar. But, you know, the Maharan classification systems has focals less than 10 mils, diffuse is more than 10 mils in length, proliferative is more than 10 mils and extends outside the stent as well, and occlusion. The problem with the Maharan classification is that it's it started life as a cardiology classification system, and obviously stents in the coronaries are much shorter and behave a bit differently compared to stents in the peripheries. So a Japanese group led by Tosaka had a new classification system which said focal was lesions less than 5 centimeters in length, positioned in the stent body, edge, or both. Diffuse is anything more than 50 mils in length, and 3 is a total occlusion. So where do drug technologies come into this? Well, drugs modulate that immune response and the proliferative response to the trauma from stenting. So anti-proliferative agents, which all started life as chemotherapeutic or immunosuppression agents for autoimmune diseases, such as paclitaxel, sirolimus, and everolimus, have been developed and put onto balloons and in stents as well, to try and reduce the proliferative response from the time of stent implantation. The trade-off to all of this is that you get a higher risk of immediate thrombosis because the platelet aggregates and thrombus within the stent interstices that we talked about first, those are not covered early. So it is really important that patients who get stents put in are put on appropriate antiplatelet agents, and certainly at the time of implantation are receiving an adequate procedural dose of anticoagulation. But what do we do when we inherit these patients who already have in-stent restenosis? So, well, we've got a number of options. For stent preservation, surveillance is important, so we're picking up more and more and more of these. But the options are plain balloon angioplasty, drug-coated balloon angioplasty, atherectomy, restenting, or a combination of all of the above. I'll talk mostly about DCBs and atherectomy, and then a little bit about the complications of each and when I would use what. You see on the right here, you've got two different types of lesions. This is clearly a higher grade lesion involving stenosis throughout the stent and indeed the vessel outside the stent as well. Whereas this one further to the right is a focal in-stent restenotic lesion. So DCB angioplasty, drug-coated balloons. So basically just a really brief overview of what is a drug-coated balloon. So the balloon itself is just a normal angioplasty balloon, but it has an incipient and excipient coated onto it, which has allows drug to sit on the balloon, and then when the balloon is inflated and you get apposition to the vessel wall, that drug is transferred from the balloon into the vessel wall to prevent the intimal hypoplastic response from occurring again. I treat these patients with plain angioplasty first to restore the in-stent stenosis to its desired luminal diameter because they're not cheap. They're more expensive than plain angioplasty balloons, and if you put one of these balloons in and you don't get the desired luminal gain, then you've essentially wasted a fairly expensive product. So I use plain angioplasty first, then I treat with the drug-coated balloon, coated with the antiproliferative agent, to try and ensure there's no negative remodeling. DCB as a sole strategy tends to work better in the in-stent setting in a more focal lesion. If you've got diffuse in-stent restenosis, you might need more debulking strategies. And again, as I said, drug-coated balloon angioplasty is not particularly useful if you can't restore the luminal diameter as desired with other either balloon angioplasty or other adjuncts. So it's pretty important that you properly evaluate the lesion with duplex ultrasound. First, you might choose to get a CT angiogram, though stents are not imaged the best with CTA. There's a bit of artifact sometimes. And then you can use intravascular ultrasound intraprocedurally if you need to or you like it. So moving on to atherectomy. What exactly is atherectomy? So it's percutaneous plaque debulking. It is not a percutaneous endarterectomy. And this is what I think some people just fail to understand. They think that atherectomy is just a percutaneous, endovascular endarterectomy. It does not take out all of the media and the entire plaque the same way that an endarterectomy does surgically. It purely gives you debulking, luminal gain, and changes the vessel compliance. There are multiple different types of atherectomy depending on which device you choose to use. So there's directional atherectomy, and the directional device that I have the most familiarity with is Medtronic's Hawk 1. There's rotational atherectomy, such as Jetstream from Boston. There's orbital atherectomy, which is Philips. There's laser atherectomy, which is more of a coronary thing. I've never used it. And then there are devices like the Rotarex, which is more of an atherothrombectomy sort of device. I've got a short little video here, which I hope it will play. Here it is. This is just a video from Boston on Jetstream. So you can see that it's not doing a full-on endarterectomy. It is literally just coring out a lesion for you. So you see you've got your rotational cap, rotational tip, high flow jet of saline and aspiration to try and get rid of the debris, and you create a lumen that's roughly that size. You might get it a little bit bigger if it's a softer lesion, because that flow effect tends to increase things. So atherectomy in in-stent restenosis, why do we do it? Well, the neointimal hyperplastic lesions do recoil early with balloon angioplasty, because the rubbery neointima, to anyone who's ever exposed it surgically, we all know that it's very different compared to calcified atheroma. Atherectomy debulks it and modifies its compliance a bit, and it's got better evidence in longer and more complex lesions. It does expose the vessel to more trauma than plain balloon angioplasty, so adjunctive treatment's quite often necessary. There are a few pitfalls as well. You do need filters with certain devices, because you saw in the video that you're basically shredding through that plaque with a bore, like a tunneling or a boring implement. Yes, there is suction through that, but you may still have debris embolize, you may still trash, so fairly low threshold to use a filter. You also should probably take some caution if you've got single vessel runoff. The vessel and device sizes you need to know about, so depending on what size vessel or stent you're trying to deal with, the device you might choose to use will be different. There is a risk of perforation with these things versus having inadequate luminal gain. So if you use a small device, so to just give an example, the Hawk 1 comes in S, M, LS, and LX sizes. So if you are doing this for a 7 mil superficial femoral artery and you've chosen to use the M device, it will be too small. You have to be careful not to overdo it. There is a risk of perforation or capture of stent struts. I don't know how many of you have seen the pictures from the early days of atherectomy of people with multiple effectively saccular aneurysms or pseudoaneurysms from the SFA, from people overdoing this. You can get early thrombosis, so intraprocedural, particularly if you haven't heparinized adequately. And atherectomy is not a sole tool. You cannot just do an atherectomy and leave. Atherectomy and drug-coated balloon angioplasty go together, because the vessel trauma that these devices cause is too much for you to just get away with a plain balloon and have good results. You'll have much more early thrombosis, early recoil, just because the trauma to the vessel is that much. You need to know the stent that has been implanted that you're trying to treat and the device itself. So atherectomy of certain stents is contraindicated. The Supera stent is a good one, if you guys know that. That's made by Abbott. If the Supera stent is basically one single wire or nitinol stent that's made, or nitinol wire that's made into a stent. So if you capture that and pull one, the entire stent will unravel, versus the rest of your stents, which have got individual components linked together. So I thought I'll quickly go through some cases to show you good and bad things. So first is a 70-year-old man who had a previous right ilofemoral endarterectomy and patch. And sorry, that should be right SFA stenting for rest pain and tissue loss. He'd had a previous EVAR, and he had a second toe amp at the time of his revascularization. His wound had initially healed, but at the 6-month review, it had broken down again with stenosis seen on ultrasound within the stents, and his toe pressure had dropped. So we planned him for a repeat angiogram and revascularization. Here you can see that I was lucky, he was skinny. So with the EVAR in place, coming up and over was challenging. I just chose to go antegrade rather than coming from the arm. and there was just about enough room to puncture the patch and get down. So you see here he's got this focal lesion close to the top end of the stent and another reasonably focal lesion in the distal stent and pretty reasonable runoff. So he just got straight DCB angioplasty. I did treat this tibial, this AT lesion, because that was his best runoff vessel. And you see there, just with balloon angio, so plain balloon first, then DCB, we got a very good result and got him healed. That's sort of as straightforward as it gets. But if you just go with plain balloon angioplasty for this, the lesion will come back. The next case is a little bit more involved. Right SFA stent, full length for rest pain. She lived in the country about 7 hours away from Melbourne. So her follow-up was a little bit sporadic. And she presented with a return of her rest pain over the past 5 weeks. She had reasonable conduit for a bypass, but she was pretty obese and comorbid, so we opted for an endovascular revision. Here is her CT that you can see at the bottom of the screen. So you see there, you've got the SFA stent completely occluded, and it's been 5 weeks, so you'll have a mixture of neointima as well as superimposed somewhat fresh thrombus sitting in there. So here's what we looked like. I came up and over in her. She was too fat to go downhill. And managed to get through the stent. The important thing here is that you do stay intraluminal or intra-stent, okay? You don't want the loop is good, you don't want your wire going outside. So what I did was I got through all of this reasonably easily. I ballooned it with just like a 3 mil balloon so that I could track a device through, and then I got the Rotarex device. So the Rotarex is an atherosthrombectomy device, and it basically mulches up the plaque at the tip just like the Jetstream, but it also has a bit of a thrombectomy component to it for that softer stuff. So this is what we looked like after 2 runs of Rotarex, which, you know, it's a pretty reasonable looking result. DCB'd the entire thing, and here you go, post DCB. So this lady had really good stent salvage, and this has all remained patent with no residual stenosis 18 months post-intervention now. This is what can happen if you are not careful. 59-year-old guy in an occluded left fempop, performed for short distance claudication, previously occluded an SFA stent. These were done in an outside hospital, and apparently the surgeon there had attempted to recanalize the SFA stent before going ahead with a bypass and couldn't get through. The guy presented 2 months after the return of his symptoms, and the bypass was deemed unsalvageable. He didn't have suitable autogenous conduit for a redo bypass, so we tried to recanalize the native vessel and stents via an antegrade and retrograde approach. Here is his CT. You see there's a long stump of SFA there, and then you've got stent down, and you think, oh yeah, this should be pretty easy, right? How did this other surgeon not get through? We prepped for retrograde access just in case there was some funny business going on. So here we go, we've come antegrade, we've got our pictures, and you say, oh, this should be really easy, right? Shouldn't be no problem at all. So anyway, through we go, you can see there's a wire through the whole thing, and we think, right, this is fantastic. Now, on that particular day, I didn't have access to other atherectomy devices. This was before we got Jetstream on the shelf. I didn't want to call the Rotarex rep in that day, so I had the Hawk 1 on the shelf, and I said, okay, fine, the entire stent's down, let's debulk it and use it. So this is what the Hawk 1 looks like. The cutter on the Hawk 1 is actually well back, 6 or 7 centimeters back from the tip of the device, the nose cone. This picture as well is a bit naughty because this looks suspiciously like a Supera stent, so I suspect this is going to end badly for wherever I pulled this from, because I didn't take, they didn't save the images of the Hawk going in to my case. He didn't have a Supera stent, so That was not the problem. The problem was we put the atherectomy device in, it made a very unhappy sounding noise, and the next picture I got was this. And you see my wire has traversed the stent struts, it's gone outside, and I suspect what had happened on looking at the original pictures, we've talked about stenting from healthy artery to healthy artery. This was not done. This stent starts and ends in a subintimal plane. So my wire has taken a beautiful true luminal path because I did get wire from below. I couldn't get any love from above. And so I had to do some fairly, I don't know, sphincter clenching maneuvers to try and get this open again. So I had the wire through, I put a balloon up here and was like, okay, the balloon's going. And then I basically pulled this back to straighten it somewhat and then said, you know what? We're not going to worry about that. We're just going to reline the whole thing with drug-eluting stents. So I put in some Zilver PTX, and you see my Zilver ends below the old stent, which is over here, and then it extends much higher as well. I put a 6x120 and a 6x200 up above, and we got a really good result with the whole thing. So yeah, in short, atherectomy is good if you need to debulk a long length of lesion and modify compliance. DCBs alone are good if you have focal lesions, but beware the lesion that doesn't respond well to plain balloon angioplasty. DCB is not going to fix it. You do need adjunct. So atherectomy is a great adjunct, but atherectomy itself it's not the main course. The drug balloon is probably the main course. The atherectomy is the entree. And beware of all of these complications. Don't overdo it. It's pretty easy to leave someone much worse than how you found them if you are too cavalier. Thank you. Any questions?
So, Vikram Shekhar here. Can you hear
Hi.
me? Hi. So thanks for
Yes, I can hear you.
Thanks for this talk. I just had one question. Is there a maximum dose for drug elution? I mean, how much of drug can you deliver through a balloon into a patient? Is there a maximum dose beyond which you can't say? Can you, for instance, cover from the CFA to the end of the popliteal? Is there a dose?
No. In short, no. You can balloon almost with impunity. There are people who say things that if you've got wounds, then bring too much drug may in fact impair the wound healing because some of these antimitotic agents will travel down and stop wound healing. But that hasn't really been borne out that much clinically.
So, I mean, if I'm to understand, then if you have a wound, then you restrict the amount of DB. Is that what you're saying?
It's more, it's a theory, right? I personally think that a little bit of paclitaxel or sirolimus, everolimus going down and lodging in the wound is small fry compared to the benefit you're getting from restoring their blood flow.
No, so is there any drug which is going into circulation as well? When you use?
Yeah, there is.
There is. So is there a restriction on how much can go through a balloon, or is it? I mean, is there a good safety margin? Even if you use,
There's a wide safety margin. So all the commercially available drug balloons now, and like for example, I think BD make a 220 mil long drug balloon. The dose of paclitaxel on the balloon is so low, and the concentration is majority going into the vessel wall that you're not getting systemic absorption of the drug.
Yeah, thanks.
Or rather, not getting meaningful systemic absorption of the drug, I should say. There is always some.
A great lecture. Thanks a lot. I just gathered, do you use paclitaxel coated balloons, right?
Yeah, generally, yes.
Okay. So not the sirolimus.
We have been involved in a trial for, I think it was a sirolimus derivative, eluting balloon. It didn't go that well, so it's not on the market.
No, sure. But in Australia, in general, you are still using more paclitaxel coated rather than sirolimus coated. Okay, fine. Because, we had a long discussion for 3 to 4 hours before your lecture. And looking at what balloons we should use, paclitaxel or sirolimus, and all the trials, showing equal benefits. So is there a particular reason that why you are still stuck with paclitaxel, not sirolimus?
Look, in vascular, we tend to lag behind cardiology. I know the coronary balloons have diversified quite a bit. We have not. I don't know whether that is from companies not having the appropriate, R&D into vascular. It doesn't pay as well as cardiology. But I think the results we've been getting with what we have been reasonable enough. So the drive to get something else on the market just really isn't there.
No, sure.
I know I personally use Zion's Prime stents if I'm stenting a tibial, and those are ever-polluting stents. But our balloons themselves haven't significantly changed for quite a few years.
Sure. And in Australia, is still a practice of, you guys are very aggressive in stenting and less of bypass, Is still the practice continuing the same way?
Yeah, it's modifying a little bit. It really depends where you work and your flavor. I mean, I still do a reasonable number of bypasses.
Okay.
Because, if we're to believe best CLI, which I think we probably should.
Yeah.
Doing a bypass implant for a patient with CLTI with ipsilateral good GSV is a much more durable solution than stenting them from, femoral bifurcation down behind the knee into the terminal popliteal, right? But I think we're seeing people live longer and longer and longer. And we find people with failed bypasses, people who had bypasses done some years ago, who today would look at and say, yeah, endo first, because you've got an SFA stump, you've got a target at the adductor hiatus. So yeah, I think we perhaps have gone away from stenting as aggressively as we did. There's a lot more use of DCB primarily, and then just spot stenting. But again, you do see patients where if you've got a dissection, if you haven't had a great result, you're locked into stenting at that point in time.
Thank you, sir. It was a nice lecture. Sir, have you done any atherectomies in instance stenosis of other areas other than SFA, like SMA, etc.?
No, I haven't. I'm not brave enough to do it yet. I've done it in an island stent, of course. That's fine. But yeah, a mesenteric, look, atherectomy is not without significant risk. You stuff up SFA, you have surgical options that aren't really too difficult for all of us. You stuff up an SMA, things can go very, very, very bad very, very quickly for you.
I know we've been focusing mainly on the arteries. Any experience of using drug-coated balloons for central veins with central vein stenosis and an arteriovenous fistula patients?
Yes. So the thing with central veins is the veins tend to be quite weak. So it can be challenging to get the drug balloons. Certainly, it's not something that we have on shelf. We have to order them in. So
Thank you.
It's something that.
Thank you, Dr. Vikram, sir. It was an enlightening topic, and thanks a lot for joining us here.
Thank you. My email address is there if anyone has a question.
Sure. Thanks a lot.
Thank you.
So we go to the next topic. We are taking again a Zoom topic currently virtually. We'll be joined by Dr. Jay Kokate, who will be speaking to us on coating technologies and challenges. I would like to invite Dr. Vinay, Dr. Brijesh Biswas, and Dr. Archana to kindly come in front as chairpersons.
I think while we get Dr. Kokate, just to let you know, he's one of the pioneers of this drug coating technology in the world. So any kind of questions, technical details you want to know regarding the technology of drug coating, please keep your questions ready so that you can answer him. He has done a lot of research, and he's one of the leading people who have actually developed through R&D the technology of drug coating. He is he's in the I think he's a biochemist, if I'm not biomedical.
Dr. Chair, you can please go ahead with your talk, sir.
Yeah, good evening, everybody, and thank you for the opportunity. Please let me know once you can see the slides. I will share them shortly. I think it's asking me to, asking you guys to let me share my desktop.
You can just share it, sir. You have been allowed.
So my background is as a biomedical engineer. I did my undergraduate education in College of Engineering, Pune, and graduate studies in biomedical engineering. Can you guys see the slides? Can you guys see the slides?
No, sir. You will have to share your screen. Share
Yeah,
the
I thought
presentation.
I did. Let me just. How about now?
Yes, we can see it now.
Okay. So really, my talk is about, I've been very fortunate to work in both coronary drug-eluting and peripheral drug-eluting technologies for the last 20, 25 years. And so my talk is really about two topics, a drug-eluting stent, Boston Scientific's Eluvia drug-eluting stent, which is truly the only drug-eluting stent that's available for the treatment of peripheral artery disease. And the Ranger drug-coated balloon, as you guys are very familiar with, this is one of many drug-coated balloons that's available, at least in the United States. So I'll start with the Eluvia. I'm going to touch primarily on the coating aspects, but I'll touch also on the clinical implications, which at the end of the day is what's most important for you and your patients. So we start with Eluvia, and the stent platform is like any self-expanding stent. This shares the same geometry with the bare metal version of Eluvia, which is Innova. It's a laser cut nitinol stent with open cells in the majority of the body of the stent and closed cell design from at the ends. And that's the goal of that is to really optimize the forces that the stent imparts on the vessel, while making sure that it has adequate flexibility for the tortuous anatomy of the SFA, and at the same time fracture resistance. The fourth thing that we designed the stent was for uniform geometry, so that you have uniform drug distribution across the length and the circumference of the treated vessel. The delivery system is a typical self-expanding triaxial delivery system, 6 French across the entire matrix, O35 guide wire compatible. What's unique about Eluvia's design is the coating that goes on there. And the coating is a polymer-based coating. Now, for those that are familiar or have used coronary stents, this shares the same exact polymer as the Promus coronary drug-eluting stent that's manufactured by Boston Scientific, as well as the Xience coronary drug-eluting stent, which is manufactured by a competitor, Abbott. And the unique properties of this polymer are that it's extreme vascular compatibility. It's known for its hemocompatibility, and it really, at this point, more than 20 million patients have had either a Promus or a Xience stent. So there's a long history of good biocompatibility. One of the key features of having a polymer on this stent is that it allows you to do a couple of things. One, it allows you to have a very low dose density of the drug. So if you look at the measured dose density of the stent. It's about 0.167 micrograms per millimeter square of the stent surface area, which is really, really low. The other thing it does is it allows a very localized delivery of drugs. So, for example, if you look at the mechanism of how the drug is delivered, it is through a diffusion gradient. You have high concentration of drug in the polymer and none in the tissue. And so as the polymer gets hydrated upon implantation, it will swell and then it will allow that drug to be distributed from the stent. So it's a very controlled mechanism. Over time, of course, that drug dose will completely leave. So you can only control it for a certain period of time. And so the question for us in terms of a challenge is, how long do we allow this drug to, how much drug do we deliver? In this case, paclitaxel, and for how long do we do it? And so just as a frame of reference on the coronary side, both with Promus or Zion stents, that delivery time frame is about 3 to 6 months. And so the question for us was, does it make sense to have that same regimen that we do in the coronaries? But as we have learned from physicians like yourselves, the SFA is a completely different pathophysiology compared to coronary artery disease. And one of the things we learned as we were doing the research is that the timing of restenosis in stents, especially in peripheral stents, seems to be a little bit longer. So we found this research done by a professor in Japan, Professor Ida, and what he found out in his studies was that if you look at when stents are most likely to restenose in the SFA, it can happen early or late, but the maximum probability tends to be around that 1 year time frame. I'm sure this is reflected in your practice, and so this is one of the drivers for us to figure out how to dose it. The next curve I'm going to show you on the right is a PK curve. And a PK curve measures the amount of drug that's being delivered over time. So on the y-axis, you have the actual measured paclitaxel, and obviously this is done in a preclinical study in a pig typically, since we can do that in human. And then on the x-axis, you have over time. And what I'm showing you in the gray is a typical DCB curve. It doesn't really matter what company does this. This is typically a high bolus of drug, and then most of that drug is delivered in that 60, at the most 90 days. If you look at Zilver PTX's own data, this is Cook's drug-coated stent, what you see is the similar elution profile. You have most of the drug, and most of that drug is delivered by 60 days. This is well published. Cook has published this over many years. And you can see most of that drug will therefore be gone in about 60 days. Well, our understanding is that the disease happens much later in the SFA. And so when we designed Eluvia, the light blue curve is how we design the elution profile. So we provide a bolus in the early stages because that's when injury occurs upon implantation of a stent or atherectomy or balloon angioplasty. But then we sustain that release of drug for approximately 1 year. Now that can vary based on patient characteristic and lesion characteristics. But this is the differentiator of Eluvia, and we believe this is really the secret sauce of what has allowed us to have really outstanding clinical outcomes. And again, I'll go into a little bit more data on how specific this delivery of Eluvia is. And one of the ways that I think you can see this is what you're seeing on the left is the same data I showed in the previous slide. The green bars at the bottom represent the stented zones only. The purple and the red bars are 5 millimeters outside the stent. So what you can see is most of the delivery across the time frame of the drug delivery occurs in that stented zone alone. Very little, there's obviously some diffusion of the drug outside of the treated lesion, but it's only less than 5 is primarily in that stented region. Most of the curves are bars you can see are green. So this is the tissue PK, and so again just highlights that the beauty of having a polymer-based delivery system. Most of the drug is delivered in the stented zone where you want the drug to be, not elsewhere else, not anywhere else. The other PK study that the FDA actually requires us to do is a blood PK. What I've shown you on the left is tissue PK, actual measured paclitaxel levels in a pig model. What's on the right is how paclitaxel actually leaves your body, and it's a drug that's really fairly easily metabolized. One of the beauties of Eluvia is that 30 minutes after implantation, you cannot measure any paclitaxel in blood. With drug-coated balloon, it's a little bit slower. So typical drug-coated balloons, for example, Ranger will take about an hour before you do not detect paclitaxel in blood. With Impact, it's 2 to 3 days. Same thing with Silver PTX. Now, this is not to suggest that there is any harm in doing that, but what it does highlight is that this is not a very efficient way of delivering drug if a lot of your drug is still in your circulation 2 to 3 days after implantation, rather than in the tissue where we really need it. So again, highlights again really the beauty of the polymer in being able to provide a very metered, localized delivery of drug to your lesion where you really want the drug to be. A comparison, now this is meant more as a comparison of the different technologies. On the first column, you see Eluvia, which is a polymer-based delivery system. And as I had highlighted before, the drug dose density is very low, it's 0.167. Silver PTX, because it does not have, in the second column, it does not have a carrier or polymer or an excipient, has a very high drug dose, relatively about 18 times more, 3 micrograms per millimeter square. You can see that the downstream particulates therefore tend to be a little bit higher with Silver PTX. Again, not to suggest that does any harm, other than to highlight that it's just a less efficient way of delivering the drug. And then on the third column, I'm showing you a typical DCB, maybe one with the highest drug dose. Impact, as you guys are aware, is 3.5 micrograms per millimeter square of the surface of the balloon. And again, the key thing I would highlight is if you look at how long the drug stays in the tissue with each of these technologies, it's 12 to 15 months for Eluvia. It's only less than 60 days for Silver PTX, and it's about 60 to 90 days. So really, this is, I will go into a little bit more detail on drug-coated balloon technology next, but I think this is a nice overview of the differences in technology. Eluvia is truly the only drug-eluting stent because it elutes for a period of time, just similar to how coronary stents do it. Silver PTX was a pioneer when they first came out, but it's clearly a drug-coated stent, not a drug-eluting stent. And of course, all DCBs are, by their very definition, coated technologies. They do not enable the sustained release of the paclitaxel in tissue. I think this is really more about the technology, but I want to touch on the key question that many of you may be asking. That's great that there are differences in technology, but what do the clinical outcomes look like? And others may have spoken to this, but really one of the first head-to-head clinical trials was done with Eluvia against Silver PTX. This was done now several years ago. It was a randomized controlled trial globally done, about 500 patients that for the first time compared Eluvia with Silver PTX, the only other paclitaxel stent that was available, that is still available in the United States. And even though this was not designed to be a superiority study, it was really designed to be a non-inferiority study. The post hoc analysis found out that Eluvia demonstrated a statistical significant primary patency compared to Eluvia. And I think that's the proof of the pudding. I can talk about the design and how unique and targeted the delivery of the drug is. And as I will highlight in the next couple of slides, it's really the clinical data that shows how outstanding the outcomes are. One of the things that I also wanted to highlight with the clinical trial data, this is the imperial data, and now 5-year data is available, is how consistent the outcomes are, irrespective of the lesion type. As the lesions get more complex, the outcomes don't really change. So, for example, the long lesion subset is again 90% plus primary patency. Same thing with diabetics and chronic total occlusions. CTO is probably one of the more challenging subsets, is probably at the low level. But other than that, I think consistently, and I always call this coronary-like outcomes, 90% plus primary patency, TLR rates in the single digits for the most part. A couple of other slides that I want to, and we don't have enough time to go through all of these, but all of these are available in the public domain, published or presented at different conferences. I think historically what we have seen as on the x-axis, if you look at the complexity of both lesions and patients, as that complexity increases, the outcomes, typically with bare metal stents or even with silver, continues to go down. And what I think we take special pride in seeing is that irrespective of lesion complexity, the outcomes continue to be consistently 90% plus primary patency. Even the TLR rates, when we look at them at 2 years, are really 90 plus or less than 10%. So really, most of these patients are not coming back, even at 2 years. So really outstanding outcomes in a very complex patient and lesion population. This just highlights the body of work. I think we invest fairly heavily in technologies, but as much or more we invest in generating the clinical data to convince you that this is truly outstanding technology in terms of delivering truly great outcomes for your patients. And again, there's a number of studies, some done by Boston Scientific. You guys are familiar with this pyramid that shows the level of data, both from randomized controlled trials as well as non-randomized registries that has been generated. Again, I'll switch over to Ranger, but I'll pause for a second to see if there are any questions that I can answer, and we can always come back to Illuvia if there are any questions. Should I continue on to Ranger? All right. I don't hear from.
Yeah, thank you for very interesting talk. I've got one question. As a clinician, this is may sound very basic question, but I just want to understand, how do you design a polymer to release the drug over 12 months? So the second question to that is, how do you measure it? That do you cut the arteries and take the samples of the arteries?
Yes.
And the sustained paclitaxel at 6 months, let's say in the pig or arteries or animal arteries, is it because of the polymer attached to the paclitaxel, or is it because of the sustained release? So how do you differentiate that?
Yeah, so just to give you a little bit of background, we looked at a number of different polymers. And the analogy that I always give is a simplistic one. In the United States, I say, I use the sugar and the donut analogy. You can change, so for example, I can take, the key thing that we always look for with the polymer is it biocompatible? Is it vascular compatible? Is it durable? Because again, the mechanical forces are significant in the SFA. And the third thing we look at, is it tunable? Can we allow the drug to, does it allow the drug to go for a short or long period of time? Typically, most polymers will dump the drug. So for example, as soon as a polymer hydrates, it will typically release all of the drug in there. So some of the levers that we use, so for example, as a simple example, and again, this is where I give the recipe of a donut, but in India, I could do bhajia. The amount of mirchi you put in the bhajia, chili you put in the bhajia is going to make that less spicy or more spicy. Similar, I can put 5% paclitaxel or 10% paclitaxel. The elution profile is going to be different. So that's one of the levers. There are many other levers from an engineering process perspective, but just simplistically, you can change the amount of paclitaxel, make it 5% or 10%, and that release profile is going to be different. The drug doesn't really attach to the polymer; it's mixed in with the polymer. So the way we coat these stents is that we take the polymer, we take the paclitaxel, we mix it all together with the solvent. And the solvent is usually, upon exposure to heat or temperature, or even normal room temperature, will vaporize. And so what you're left with is this matrix that contains the paclitaxel embedded inside the polymer. And as soon as I said, as soon as the polymer comes in contact with water, it swells. It swells. It actually swells. It grows in volume. The water gets inside the polymer. And that then allows the molecules of paclitaxel to move inside the polymer. And because it's driven by diffusion gradient, there's a higher concentration that's going to go away from that polymer. As long as that diffusion gradient exists, which is always going to exist in the tissue will clear out the paclitaxel. You will always have this one-way direction of the polymer to the tissue. Does that explain it?
Yeah, thanks. Actually, want to know this paclitaxel dose, how much we can give to her one raise for any patient. So that is any limitation of the dose, or we can use any times of her.
Again, another really good question. We test these for a wide range of doses. Obviously, the amount of drug dose on a paclitaxel eluting stent with the polymer is much, much lower. And so, if silver has been tested and it has 18 times more drug, so obviously there's a huge safety margin. We do these studies, FDA requires us to do these studies. We have tested paclitaxel doses with Elution 3x that of what you currently have, and there's no concern. And of course, silver PTX proves that you can do these at a much significant higher level and not be concerned.
And another question I want to ask was, how much drug is lost while we are putting the balloon through the sheath, and by the time it reaches the target lesion, and how quick we need to inflate the balloon? Because if you're saying that with the blood, the polymer swells, and if it is coated on the balloon, and if I'm, let's say, wasting a minute without inflation, so maybe the drug, because there will be, if it acts on the diffusion basis, the drug may be lost from the balloon into the blood rather than on the blood vessel wall.
Yeah, maybe I can go through the DCB presentation, because the mechanism with the DCB is very different than with the stent. Silver PTX and DCBs are similar because they are coated. The mechanism for both silver PTX and DCBs is not diffusion gradient. And maybe I can, if you're okay, I'll go through that. And
on the stent, if I may?
Yes, of course.
You showed some fantastic results for the 12-month out, and from looking at your data, it looks like by about 12 months, most of the drug diffusion has stopped. Do you have any data on file for the longer-term study outcomes of your Imperial trial or any of those, even if it's not published?
Yeah, no, it is published now. So 5-year, again, as you would expect, the numbers do go down because, as you rightly pointed out, the drug is only there for 12 months. We do believe that there's some residual patency benefits to having that drug for 12 months. So I'll tell you what the outcomes are with Imperial. They are 65% primary patency at 5 years. There have been other studies that have also, Munster is another registry that may be worth looking at if you're not familiar. And it actually had a very complex patient population, about 200 millimeter average lesion length, a lot of CLTI patients. And for that study, the outcomes are the freedom from TLR at 5 years is 80%. So again, the primary patency again is close to 70% with Munster. So the outcomes for 5 years are obviously not as good as potentially a native vein bypass, but really much more out. I think historically what I've always heard is we would be lucky to get with the bare metal stent 20-30% primary patency at 5 years. But both and again, I can either through Abhinav or one of the bosses anyway, I can, my email address is, I don't have it on here, is j.kokate@bsci.com. I'm happy to send you, so many of these have been published, so I'm happy to send those two out to you.
Thank you. Jaideep, I've got another one very basic question. Sorry, it's just always tickles my mind. You know, we are putting these drugs to prevent neointimal hyperplasia, right? But we also want the neointima to be there in the stent. Otherwise, you will have the bare metal exposed to the blood and will cause thrombosis. So if we are delaying and having a sustained release, so that will also prevent a neointima formation also, isn't it?
Yeah, so yeah, it's again a very good question. You should come join our team because these are some of the questions we ask ourselves. So one of the things that and again other physicians have also asked this question. I think the reality is we want endothelialization so there is no risk of thrombosis, and so the Japanese have been very cautious about that. And so we, on the preclinical side, we look at immunohistochemistry to make sure that at 16. So when we look at how long does it take to endothelialize, it's about 90 days in a pig model. So while you have minimization of the stenotic process, you still cannot limit. Body tends to completely encapsulate implants, and so you see endothelialization typically in all our studies by 90 days. In the OCT studies done by the Japanese physicians that I mentioned, Ida and Sei, they see endothelialization as seen with the OCT in less than a year. And so even though there is drug present at a very low level, understand that at 1 year, the levels of paclitaxel are about 1 nanogram per milligram of tissue. So it's really very, very low levels of paclitaxel.
Sure.
Seems to inhibit neointima, but does seem to allow endothelialization of the stent.
Sure. Another very small question. So going by this, if paclitaxel is more stronger than the sirolimus in inhibition of the split muscles, so then sirolimus will be better for a long-term release than the paclitaxel, because that you will have a neointimal and less of neointimal hyperplasia.
Yeah. So again, great question. We obviously, Boston's the only company that has historically worked with both paclitaxel and limus or sirolimus or one of the limus analogs. And here are some of the challenges with limus. And of course, we considered, should we use limus instead of paclitaxel? And the challenge for us is multifold. One, many of you are familiar with STRIDES, which was done by Abbott many years ago, and Sirocco, which is another trial that was done by J&J. And the challenge is none of those worked in the periphery. And again, to your point, paclitaxel seems to be much more potent. So that's one challenge, that the clinical data in the superficial femoral arteries has not been very compelling. Secondarily, as pharmaceutical and chemical engineers, polymer scientists, one of the challenges that we see with everolimus is that it's really, really hard to sustain it for a long period of time. We think the secret to Eluvia's success is that we can sustain it for a year. On the coronary side, you can sustain it for 3 to 6 months, not a problem. We are able to do it for 6 to 9 months today, but to try and get to that 1 year time point is really, really difficult. It's just a less stable compound. Everolimus as a pharmaceutical agent is a much unstable compound, and to try and sustain it for 1 year is a challenge. So those are the two big challenges. A, the clinical data historically has not been very compelling with limus in PAD, and two, it's a really much harder drug to control and do this sustained release for about a year, which we think is the key.
So we are running really short of time. Could you just run through the Ranger technology?
Yeah, and what I'll do is I'll go very quickly through the range. again, the history of this is drug-coated balloons are the concept of delivering antistenotic therapy is not new. Boston Scientific has been working on it since the mid 90s. These are published papers, a couple of different versions, and none of these really worked. And the challenge that these didn't really work is because your endothelial layer tends to be a pretty big barrier to delivery of drug. And this is where I say, unlike Eluvia, which is a drug-eluting stent based on a polymer, the mechanism here is that you coat the balloon, and you coat the balloon with a crystalline form of paclitaxel. The excipient is like a binder, right? Just like aspirin is not 100% salicylic acid, it has things like cellulose to allow delayed delivery of drug. All these binders are doing is making sure that the drug is not lost during transit. I thought there was a question on how much is lost. A significant amount of drug is lost in transit, both upon entering the sheath as well as upon inflation. But you still get some drug there, and the mechanism is that you get crystalline drug embedded into the vessel wall. So that's the mechanism. The image on the right, on the bottom, shows that the green image is actually crystalline paclitaxel. And over time, that will dissolve. This is where the excipient is important. If you don't use excipient, again, this is a PK curve similar to what I showed you before. The green and the black are ones that didn't have an excipient, and you can see you get very little tissue retention, very little in the tissue. As soon as you add an excipient, you can extend that duration of release. And so that's the criticality of the excipient. Every company uses a different excipient based on their patents and intellectual property. We use something called ATBC, and that's really allowed us to do two things. One, maximize how much we get into the vessel wall and minimize how much goes downstream. But it is going to be, I will tell you, even though work on Eluvia and Ranger, both Ranger DCBs in general are not as efficient a way of delivering drug as Eluvia or a polymer-based system is. This is upon hydration. Obviously, this addresses your question. What happens once because the coating will come in contact with blood or fluid in this case, as soon as you hydrate, again, you see that some of that coating is going to come off. At the bottom, you see flaking from the impact coating, which uses urea as an excipient. And then if you look at downstream particulates, this is what's lost either during insertion into the sheath or upon inflation. And I will transparently tell you, this is well published, a majority of the drug is, with all drug-coated balloons, as well as with silver drug-coated stent, is lost downstream. It's less for Ranger, even though the drug dose is the same, and that's based on the choice of excipient. So for example, Lutonix has a very water-soluble excipient, and so it tends to lose more of the drug, even though these guys have the same exact drug dosing, you lose a lot more with it. Lutonix. Lutonix is the only drug-coated balloon that requires you to get it to the lesion within, I forget whether it's 120 seconds or 180 seconds. We don't have that restriction with Ranger or Impact or any of the other DCBs, only with Lutonix. And so again, that is important from a safety perspective, perhaps. What is more important is how much drug do you deliver into the vessel wall? And this is where, even though Ranger has half the dose on the balloon surface as Impact, you can see that most of that, there's no difference in terms of the PK curve. It's the same amount of drug is being delivered by both these devices actually into the lesion. And so this is, again, preclinical or pig data. I won't spend too much time on the delivery profile, but what you can see is the Ranger has the highest primary patency now out to 5 years. And this is, I'm doing a little bit of an apples to orange comparison. This is every company's clinical trial that was submitted to the FDA. So again, highest primary patency with Ranger compared to all the other devices. I know this, again, I'll pause. I know you guys are running late. What I'll say is, like Eluvia, we've built a strong base of evidence on the use of both these technologies for the treatment of peripheral artery disease. And I'll stop there, but I'm happy to answer any questions that you might have.
So thank you very much. We would like to go to the next talk. Thank you. Thank you
Great.
for joining us, sir.
Yeah, of course. My pleasure.
I think we'll go to the next Zoom presentation again. Uh, we'll be discussing on Basel 3. Dr. Raghu Lakshminarayan, can you connect to him? So you could please go ahead and share your PowerPoint presentation.
Thank you. Can you hear me? Can you hear me?
Yes, we can hear you.
Oh, perfect. Let me increase my volume. Right, I'll share my PowerPoint presentation. I know that you guys are running a bit late, so good afternoon from my end and good evening from your end from the cold north of England. I think it's about 1 degree centigrade. It says the host disabled participant screen sharing. So if you can get that going, I'd like to thank Dr. Shekhar, Piyush, and the team for giving me an opportunity to speak at this meeting. I will try again to share. I'm still disabled from the point of view of sharing, but let me try again. Yeah, that's great. So thank you for the opportunity. I think it is the right controversy because we're asking ourselves the question: has Basel III trials muddied the waters? The point is this: the Basel III trial has not been published, so this talk is going to be a bit philosophical and a bit on documentation and a bit on evidence. We are a very high recruiter for Basel. In fact, for the Basel II trial, we were the second largest recruiter in the trial. And we put in about 8% of patients into the Basel III trial. These are my disclosures. These disclosures do not have any effect on the present talk. As you can see, I come from the northeast of England, a place called Hull. Can you see my screens?
Yes, we can.
I think you can. So comes from Hull, and we cover quite a large area, large population, and Dr. Piyush Jain used to work with us, and he knows the kind of work that we end up doing. Hull has problems. That's why we are large recruiters. There is smoking, there is obesity, there's low socioeconomic state in the UK, and there's everything that's kind of a milieu for peripheral arterial disease. But Hull is also UK Sydney, for those of you who are willing to come. We have a nice bridge, we have the Deep that looks like the Opera House, and we have nice stadiums. So people who are wanting to come and work with us, don't get put off by the previous slide. We have a nice big hospital, and on the second floor of that hospital and third floor of the hospital, we do most of our work. Now, I'm going to be a bit cheeky and take you through a very interesting trial called the Random Stop Study. So what they did was the aim was to assess the proportion of patients undergoing endovascular therapy for FEMPOP disease who are eligible to be taken part in major trials. What would have happened is all of you will be talking about a huge number of trials. about drug elution. Now, how many of our patients actually would fit that trial to look at that evidence? What studies tend to do is they enroll highly selected patients, and outcomes may not be fully applicable to your daily practice. Now, let's look at this. 16 centers were taken and 1,600 patients were enrolled. And these were the trials. And I'm sure from the morning you've been hearing all these trials: Impact SFA, Levant 1, and all the other trials, Zilver PTX, etc. So what I want you to do is, if you can scan this QR code and tell me what percentage of patients would be suitable to include in all these 7 studies. Now, you can even go to slido.com and just enter that. You don't have to register or anything like that. If you enter that hashtag, you will be able to. So give me a number. Now, what they did to give you a backup is that they took 1,600 patients and then they put in how many of all these patients would go into all 7 studies. So I just put in 30, somebody has put in 10%, somebody's put in 20%, somebody's put in 60%. So as there's a weightage. So basically, let's take an average and say, okay, about 25% of patients would go in to all these studies, 7 studies, okay? Here's the verdict. The number of patients who would go into one study is 15%. And the number of patients who would go into 7 studies is 0.13%. So what we are doing here is we are sitting in various places in the world and quoting evidence from Impact SFA, Levant 1 and 2, Illuminate, Ranger, Eminent, Imperial, Zilver PTX, and we are thinking we will take this evidence and put it into our daily practice. But actually, when you took 1,600 patients who all comers who came in and put the inclusion-exclusion criteria, only 0.13% of these patients actually fitted in. Then how can you take this evidence and deliver it to the 99% of patients that we're treating? Isn't that a very interesting comment to make? So we can discuss this when we come to the end of the talk. Now, what about Basel III? Basel III, what it did was, is the use of drug-coated balloon or drug-eluting stents clinically and cost-effective in endovascular treatment? That was the question, of course, in critical limb ischemia. That was the question that was being asked. So what was being done was patients with SLI's severe limb ischemia, or CLTI, you can call it now, patients were recruited who were suitable for endovascular repair into 3 groups. So once the patient was suitable, a research nurse used to discuss the trial with the patient, get an informed consent, and then completes a baseline assessment form and randomizes the patient. So inclusion criteria were CLTI due to FEMPOP disease. They were put through an MDT, which included vascular surgeons and IRs working within an MDT environment to say, yes, this patient should be suitable for endovascular repair, and then adequate inflow and FEMPOP plus minus infrapopliteal involvement, and then they were put into 3 groups. So what were the 3 groups? Plain balloon angioplasty, POBA. I know our good friend Sunil Rajendran is going to speak about POBA after me. DCB, both in these groups with POBA and DCB, if there's a dissection and you want to stent, you need to put a balloon, plain bare metal stent, and then drug-eluting stent as a final thing. And what they did was 2 things: economic analysis and then major amputation or death. Those were the 2 things that were looked at. So compare this to Basel II randomization, 300 patients, vein bypass first versus best endovascular treatment. Basel III randomization, this was what was started. This was picked up from Professor Badbury's talk in 2015, where they were looking at randomizing 287 patients into each of these 3 arms. The key thing that I want you to remember is 846 patients, 287 patients POBA, 287 patients bare metal stents, and 287 patients drug-eluting stents. Follow-up for a minimum of 24 months, a maximum of 60 months or 5 years. So this was the grand plan when Basel III was started. Now this was, I told you we put in about 8% of patients into this trial. This was one of the patients. You can see FEMPOP disease, adductor disease. What we have done is this patient went through randomization, drug-coated, which was an Eluvia 6 millimeter stent that we put in and treated those segments. So this was what we were doing in that point. Now, what was the primary endpoint? The primary endpoint was amputation-free survival. And this is defined as the time to major limb above ankle amputation, that is below knee or above knee, amputation to the index trial limb, or death from any cause. Now, this is a very important point, that take-home point that you need to have. So death from any cause, amputation-free survival. What I'm interested in, and there are a lot of secondary endpoints that were looked at, what is the most interesting and probably something that we will discuss at the end is the re-entry and crossover intervention rates. That is an interesting topic. Now, when you look at the impact SFA 3 years outcome, primary patency, for the DCB was around 70%, whereas for just POBA was around 45%. And when you come at freedom from clinically driven target lesion revascularization, once again, the drug-coated balloon did much better than plain balloon angioplasty. And this is something that is seen through multiple trials. And this, obviously, many people will be coming to you and talking about each of these trials. But the key thing I want you to remember from this slide is most of these trials look at freedom from target lesion revascularization. And that's around 1 or 2 years' time. Now, another key problem that we need to remember is that many of the patients that we do an angioplasty sometimes come back. And that's around 4 to 6% of patients who have had an angioplasty tend to recur for recurrent treatment. And the question is, could you spot them and could you use newer technology in order to stop that from happening? So this background of plan for Basel III brings me to my topic, Basel III trial insights, has it muddied the waters? So is the Basel III data published? The answer to this question is no. The data is not published. So what I did was I emailed one of the people who was a prominent trial coordinator and asked him, said, look, somebody from Mumbai has called me for giving this talk. Can you give me some data? So this was the email cut up. Currently, Basel III headline manuscript is in the journal, not yet accepted, lots of round of reviews. I really can't share anything until it's published. Now, this is a problem because what happened was, why has it taken so long for the results to be published? In fact, Professor Bradbury, who is the chief investigator, presented the results early this year at Charing Cross. And various presenters have picked up from these early results. So there have been result leaks, if I can put it that way, almost in a political kind of sense. There has been leaks, and that is why Dr. Shekhar has nicely asked the question, has it muddied the water? So what is it that we know? So this was the question that Basel III was asking. Is plain balloon angioplasty, bare metal stent, and DCB and drug-eluting stent, is it similar in effectiveness to drug-coated? And the answer is probably yes. So amputation-free survival, the primary endpoint of the trial was amputation-free survival. After a 7-year follow-up, amputation-free survival was 34% in the POBA arm, 40% in the DCB arm, and 42% in the DES arm. So not a huge difference between the 3 arms. Clinical benefit. Once again, they said the trial did not find that DCB or DES offered a significant clinical benefit compared to POBA. What do we mean by clinical benefit? The point is, you you have a patient who comes with CLTI, either rest pain or ulcers, you do a procedure, and then clinically the patient benefits from it, whether the vessel is patent or not, who is bothered? Because from a patient's point of view, it is my father who's 83, and he has critical limb ischemia. Then what will happen is his ulcers have healed, he's going around, he goes and gets his newspaper, he reads his newspaper, he's happy. So what's the point? Why do you go around checking, is this patent or not patent? Who cares? And then cost effectiveness. The economic analysis found that the cost effectiveness of all three interventions varied based on patient level data. In fact, they found it was more expensive, and I don't need to tell the Indian audience, obviously it's more expensive to use drug-coated technology compared to plain on balloon. So teasing the results out a bit more, between January 2006 and August 2021, 481 patients were enrolled. If you remember, when I started off, I said in 2015, the plan was to enroll 800 odd patients. But now that dropped down to 481 patients. And why? Because COVID was involved in the process. And also there was a Katsanis pause that we can talk about. And then they looked at amputation-free survival. They didn't just look at amputation related to CLTI, they looked at amputation-free survival. So the intention to treat analysis, 34% for POBA, 40% for DCB, and 42% for DES. And actually, when you look at per protocol analysis, it is even closer, 35, 39, and 40, right? So there are some questions. In fact, when I was at the VSI conference in Jaipur, somebody said, oh, the trial was not powered sufficiently. No, the trial was powered reasonably well, because what was required was more than 291 primary outcomes. And so the trial power exceeds 90%. So the trial was definitely powered. The Katsanis pause of 2018 affected recruitment. What happened is, most of you are aware, Costas came out and published that paper where there was a signal of mortality in paclitaxel. Then what happened was people stopped using paclitaxel. There was a lot of discussion, and we had major organizations in the country saying you have to consent patients for a signal of death due to it. So people stopped using it, and that was a major problem that affected recruitment. The next question which we need to discuss, has the power calculation taken into account the role of death versus limb outcomes? Because we are interested in limb outcomes and not necessarily death. Of course, patients are interested in death. And the problem is death due to COVID, because nobody knows whether the patient had a successful angioplasty, had the limb, but died because of some other cause. For example, COVID, because this particular trial went through that particular time. The other thing that has evolved over that time is vessel prep. Now, we tend to do a lot of vessel prep before we do drug-coated technology, be it drug-eluting stent or drug-coated balloon. Vessel prep was not a major practice at that time. So what are the take-home points? The findings cannot be taken in isolation. So I would say, if you ask me, look, based on these, and you say you're a top recruiter, what are you going to tell us? I wouldn't take the findings on isolation, but I would also not take the findings to say that drug-coated technology is the be-all and end-all of keeping a vessel patent and taking it forward. So what I would do is the cost of DCB and DES is a concern. I would take it into consideration. I would probably use it in task 3 or 4 lesions when it comes to drug-coated technology, because these are long lesions. The patients are probably not suitable for a vein bypass. And when you treat long lesions, we know that the success of patency is low. I would use it in calcific lesions, of course, after calcium modification with some kind of atherectomy or intravascular lithotripsy or something like that. I would use it in re-interventions, because these are patients who are coming back with a significant amount of aggressive disease in which you would want to use this particular technology. And the role of sirolimus is evolving. You would have noticed that there are a couple of Japanese studies that have come out which are showing really good outcomes. And I know that Eddie Choke is giving a talk tomorrow morning, and I'm sure that he will talk about the sirolimus and concept balloon. So with that, what I would do is I would ask you to put some questions on. You can similarly use the same slido.com, and I can also take questions from the flow. But if you're not happy to talk out and you just want to type out a question, it'll be easy. This will come onto it, and I can pick it up. And thank you enormously for having me for the talk, and thank you for listening to me today.
Thank you very much, Raghu. This is Gnanish here. Can you hear me?
Hi, I can hear you very well. Thank you.
Yeah.
Thank you for the opportunity.
Thank you. As you rightly mentioned that the trial results are not published, so whatever we discuss here is theoretical. So I'm really happy.
I would just, Gnanish, I would just preface it by saying that the results that I have shown is already in the public domain.
Yes, I understand. So yeah. I'm really glad that you showed the initial slides about the recruitment process. I think I am specifically not looking forward to even read the trial when it is published, because as you rightly mentioned, it is highly selected population and there are so many factors that bias the results of this study. Especially when you say there are 35 centers in UK that has recruited over a period of 6 years, 481 patients, it means that less than 3 patients per center in a year time. Okay. So I know there were few other factors like the COVID, and then there was this paper that showed that the mortality was high, so the government has stopped recruiting into these trials. But what is your view on this? Would you really look forward to read these results, and would you use them in your practice?
So those are very good questions. So what I am interested in and what I went back to try and find out was the trial has looked at re-intervention rates. So that is a very important component, I think, that the trial's sub-analysis will bring it out. So my question is, what is the re-intervention rate when you look at drug-coated balloon or drug-coated stent much lower than the re-intervention rates in POBA? Because that is going to influence us. Look, we have to be honest. I don't think anybody in the UK, the use of drug-coated technology is still in less than 10% when it comes to primary PTA, right? So when a patient comes to you and has a lesion and you're doing an angioplasty, you don't jump to a drug-coated technology in the UK. And I guess similarly, because of cost concerns, it'll be something similar in India. So the question to us as a group of doctors who are performing this is, can we pick the patient who would be benefited from this particular technology? And I think if the re-intervention rates are proven to be low, then maybe, like I told you, TASC and D lesions, maybe you may want to use it. Calcific lesions, maybe you want to use drug technology.
Dr. Raghu, hi, it's Dr. Rahul Jindal here. Very nice talk, and I think I was definitely not aware of the results. I haven't read it, and it's these results are very important for our country, especially because in day-to-day practice, it's very difficult to use these expensive technologies. So we were exposed to drug-eluting balloons like maybe 10 years back, 8-9 years back now, and I've been very, very selected with using of drug-eluting balloons and stents for various reasons. One, I always believe that the drug will wash off while we are putting the balloon by the time it reaches the vessel. And my mind could not understand how will the drug enter the vessel's wall in just 1 minute inflation. How will the drug stay there for a longer time? Though, you know, of course, theoretically in the pig models and all, we knew everything what is happening. But does it really make a difference in the humans as such? We didn't know about it. I think this trial will be very useful for putting a something like a pause and think about it, and giving a way forward to do more studies before we take it blindly, these technologies, and start using them in each and every patient. I think that's a very, very important study where sometimes you have to step backward and see are we really going into the right direction or not. And the only thing is, if you look into the coronary studies, there are thousands and studies which have been published, and they show that the drug-eluting stents, they really work and all the stuff. But sometimes we may not be able to collaborate that studies back into the peripheral systems because it's a huge arterial system, it's a huge surface area, and the coronaries may be may be different as compared to the peripheries.
You bring up such a very important statement there. The comparing the coronary space to the peripheral space is very difficult, and the amount of money that has been spent in the peripheral space, we have spent about 20 million or 25 million US dollars on randomized controlled studies. The coronary space, they have spent almost about $5 to $6 billion on randomized controlled studies. So evidence collection in the peripheral space has been very low. I will ask you and your participants to think of one scenario. I was in the clinic last week. I had a patient who had rest pain and a small ulcer in the foot. We had done angioplasty on the patient, and then he came back on a follow-up. Rest pain's gone, ulcer's healed, and he says he goes to the local shops and comes around. He obviously will be a claudican, but I did a quick duplex. His SFA pop lesion that we had angioplasty had gone. Is this a success? This happened to my own father-in-law.
Yes, this is a very common practice. So this is a success for us. It's a very, it's an amazing success. You see, when we were in the initial practices 15, 20 years back, all Shekhar, me, and all the senior guys, so we were very aggressive, and we used to check up the duplex scan, re-stenosis, re-interventions, and we realized that all these patients come back with a vengeance. They used to come back with a longer occlusions when we used to do the re-interventions. And 10 years from now, we actually stopped doing the re-interventions in all these patients if the patient is just a claudicant. And when we put these patients on lifestyle modifications, on the best medical treatment, all these patients, they really go very well at just need to keep a bit of patience, and 6 months to 1 year to 1.5 years, they actually could walk up to 1 to 1.5 kilometers. And when they are able to walk, this actually remains for a very long time.
Precisely, you make such an important point. So when you look at, and that's why I said, when you look at all the other studies that are quoted, they all look at patency, be it Silver PTX or anything like that. But what are we interested in? We, in this study, and that's why I think you should read this study, because what we are interested in is amputation-free survival. If the patient's amputation-free, surviving and going about their life, that is success. And how you achieve that success is left to you. You could use drug-coated technology or not.
Raghu sir, thanks a lot.
Can I, one quick question?
Last question.
Yeah, thanks. Hi, Raghu, Robbie here. Thanks for a great talk. I mean, a lot of very incisive comments on the basal trial. So in the interest of time, I'm going to keep the question short. Compared to the real world, when you look at your own recruitment for basal 3, what percentage of your patients did you end up recruiting to the trial or who was suitable to be included? And how would you think that reflects in terms of the practice that we have in India, which you're well aware of?
I would say that, I mean, I don't have the exact numbers, Robbie, and it's nice to hear your voice again. I would say that it would be around 5 to 8% is what we would have recruited, because we are looking at good inflow and just FEMPOP disease that patient had. So it's not a huge number, but what I would also say is that our practice has not changed enormously. Our drug usage, just so that you're interested in, we do about 700 odd angioplasties per year. Our drug usage is around 10% or even lesser.
Thank you.
Thank you, Dr. Raghu sir. It was a very enlightening talk. Thanks a lot.
Thank you. Thank you for having me.
I would request our next set of chairpersons to be in front. Dr. Sandeep Pandey, Dr. Shardul Date, and Dr. Vivek Sawant. I would invite Dr. Tapish Sahu to speak on role of drug-eluting stents.
Thank you, Anirudh. Thank you, Vessomag, for having me here. And I think, Secretary VSI, first of all, I would like to congratulate each one of the Vessomag members. These theme-based meetings are very important, and we focus on some in-depth analysis of certain things which get missed in the annual conferences or even the midterm. So there is a small VSI happening here. Thank you, Vessomag. Thank you, Shekhar sir, and everyone from Vessomag for having us. So I'll be speaking on the drug-eluting stents. It's a vast topic, but some things have already been covered in the previous talk, so it makes things easier. Robbie sir was talking about some marriages, and I think that marriages with the drug-eluting technology, with a stent, it's a perfect marriage to sound, but well, everybody of us will agree there is no perfect marriage in this earth. So we'll talk about the designs. There are three components. One is the stent, then is the drug, and then is the polymer. That actually are the three things that are essential for the success of the stents designs that they have made. If the struts are thicker for having more drug, that makes it again in the long term not as useful. If the polymer is itself causing some problems, the shellolic acid, then they have the fluoropolymers, they have urea, then they have no polymers, and then gradually the terminology changed from a drug-eluting stent to a drug-coated stent. I'll come to that also. So these are the three things that are essential in the design of a stent, and all that my talk will have today is that Vivek sir does not like, but studies, the double-blind studies, which I don't think that have any meaning after Raghu sir's talk, and the RCTs that I don't know what it's actually measuring, but well, I have to talk about the stents and the data. So the Eluvia stent, which is right now available in India, the silver PTX, from where this story was, it picked up very well. It was measured with the bypass also. They had a randomization, they had long lesion, they had 1 year results, 3 year results, 5 year results. Then there was the Abbott Dynalink E, the sirolimus, the Cordis J&J that they started with, and the Nitidase, that's the LV Medica. I will come to the details of that. This had a drug, the limus, that was the amphilimus, which was sirolimus, plus a fatty acid that they had as the drug. The others, taxils and the limus, will come to that. So coronaries, from where this was picked up, actually where it all started, that okay, you have an anti-proliferative technology. In the FEMPOP, it's accelerated restenosis. Based on that, the silver PTX first was approved in 2012. There was improved patency, freedom from TLR, that was the endpoint, suggesting incremental benefit over the, at that time, whatever larger studies were there were bare metal stents. And then came the Eluvia in 2018 that was approved. So this paper in 2024, JVS Vascular Insights, talks about drug coating and drug eluting, that Dr. Joy was talking, that without a polymer, it is actually a drug coating, not an eluting, because you need the elution to be happening at the time that Dr. Joy was saying, at 10 to 12 months. So silver PTX did not have a polymer, and that was in fact the terminology. All the papers initially started with the drug-eluting stents, but then they came out to a drug-coated stent. So If you talk about the balloon, again the same thing. Can it be a DCB or a DEB? So you can't have a balloon which is eluting later on. It will be a coating that's there. So the terminology should be a DCB rather than a DEB. So peak incidence happens at 10 to 12 months that Dr. Joyce showed. Eluting stents characterized by polymer coating, while without a coating, it is a drug-coated stent which actually gives off the drug in maximum 60 days. Particularly advantageous in preventing restenosis. That is the time when the restenosis will occur at 10 to 12 months. So is it secreting the drug at that time? Is it eluting the drug at that time, or is it gone? So coated stent is polymer free, more rapid drug release, which may be beneficial in different clinical scenarios, but could also result in a shorter duration of the therapeutic effect. So this was in Vascular Insights, and when they did a study that if you see the graph, as soon as the Eluvia was released, the drug-coated stents started to coming down and the drug-eluting stents went up. So this is actually the transition happening for the Zilver PTX when in 2018, the graph that you see coming down, actually that was the Zilver PTX, and the going up was the Eluvia. In CLTI patients also, in diabetes patients also, this was the analysis that these people did in 2024. This was published just now. So Limus eluting stents, 2002, the Sirocco trial, the sirolimus coated smart stent, 6 months. I won't go too much into the details. All I want to highlight is just 36 patients were there in this trial, and they did not reach any statistical significance. Sirocco 2, they said, okay, let us continue the trial, let us come up with more data. The incident stenosis were 22.9 and 21%, so they said that they're lower but not significantly. Still, what you see is a 46 patients in the Sirocco 2 trial also. What previously was talked was that we need larger numbers to come at some conclusion, not these 30, 40 patients, but well, they paved the way for the larger studies, and every study that you will read, in the end, the disclaimer is that we need larger trial, we need larger trial. That is how every study has to end. So STRIDES trial, 104 patients. Everolimus drug-eluting stents, this came to the with the Limus technology. Overall results seemed very similar with the bare metal nitinol stents. Primary patency, 68% at 1 year. Elvemedica, polymer-free. Then again, this was a coated stent loaded with amphilimus, that is, I talked about the fatty acid. And then the 1 year, 2 year, the Illumina first in human study, that 24 months, the patency and freedom from TLR was 83% and 93%. They said, well, this is one of the good studies that they are having because the polymer is a little different, so that's why the drug is better off. Then the paclitaxel, they have made a lot of comparisons in the Cook made with the Zilver PTX versus POBA, Zilver PTX versus covered stent, Zilver PTX versus longer lesion, Zilver PTX versus bypass. So 1 year, the paclitaxel in the 2011, this study said that 1 year, Zilver PTX, superior 12-month event-free survival and primary patency, that was 83% versus 32%. That was just the POBA. So that was very significant at that time because 32 versus 83%. At 5-year data presented in Charing Cross at that time, we attended that. Some of my seniors would remember that, okay, this was being presented, that provided sustained safety and clinical durability that superseded POBA, said, okay, this is a good stent, this is a promising stent. Then came the battle trial, which said that with a mimetic stent, that was at that time, the Supera they didn't have, but with the Misago BMS, they said that there was no difference in rates of instant restenosis at 1 year. Now, this was a finding that again, till 2 years, they studied this and said maybe that the design of stent, and they said that if you have a stent that can sustain the SFA forces, may not need that drug technology at all. If you have a mimetic stent at that go, which is not exactly a bare metal stent, but a vasculomimetic stent. So that then they started thinking more. They had this Zilver pass, which means Zilver with a bypass, RCT. They had the comparison with surgery. They compared with surgical bypasses and thought that non-inferiority in terms of safety and efficacy, let's see. So at 1 year, primary patency somehow was almost same and statistically insignificant with a lower rate of perioperative complication and shorter hospital stay. Well, that was at 1 year, but the inclusion exclusion criteria, if we go in detail, they said that it was almost similar at 1 year with the bypass. Imperial trial, eminent trial, Eluvia versus Zilver PTX, one-on-one. Dr. Joy was mentioning about the imminent trial. Then there was the the Imperial trial and the Imperial long study. That was 3-year results they had published. So at 1 year, they said that improved primary patency with decreased major adverse event with Eluvia. Biomimetics, whether this addition of drug coating is really required with the current biomimetic stents and with a proper bed preparation, is that actually required? Eminent trial said that primary patency at 12 months was significantly improved in Eluvia stent arm. Improved life dimensions. Now this was important because they said that eminent trial also focuses on quality of life. Previously everything was about the amputation-free survival, TLRs. Then they said, what about the quality of life, which should be matching the real-world scenario? And this eminent trial was the one which talked about the quality of life, pain-free survival, discomfort for a majority of patients without significant difference. Said that not too much of a difference. They found that, okay, both the stents are having almost same quality of life. So question of long-term safety of paclitaxel coated devices that has been asked again and again, that whether they are safe, whether this elution going on, that Dr. Rahul asked that after 1 year if this is eluting, that there are pockets there, if you are eluting a drug. So they said that, okay, then this meta-analysis, the famous Constantino's pause that happened, was this study that is quoted below, that in 2016, after that, this was published in 2018 in Journal of American Heart Association. Then this said that the relationship was there with worse long-term survival compared with uncoated devices. Now, this is what every government had taken a cognizance of, and the US FDA said that use it with caution, use it only for highest risk of restenosis, do not use it routinely. And this was the US FDA warning in 2019, after which everybody, that is what Dr. Raghu was talking about, the long pause. Eluvia stent associated with accelerated development. So as was talked, that everything that has been told to you, take it with a pinch of paclitaxel or a pinch of salt. Do not swallow anything and everything that has been given to you. So this, as Paresh sir was asking, that accelerated development of aneurysmal degeneration, because there is a drug, the remodeling is not happening. The Devinder said, and Ilan sir talked about the the media degeneration that is happening. Sometimes that is what is termed as the halo sign, and halo sign was actually that came into picture in porcine models. Eluvia stent was found to be associated with aneurysmal degeneration in compared with Zilver PTX. So then there comes a drawback. As you go along the road, you find that there is no perfect marriage. Actually, that's what I was mentioning. And then further on, the Imperial trial, the Capsicum registry came, and then they said that whatever way they were finding that halo, they said, no, we are not finding the halo now. So no difference in halo prevalence between Eluvia and Zilver PTX. Then they said USG follow-up to assess this endpoint was only available in 27% of the patients. And this study said, this Imperial trial said that, okay, now they have studied only less than 30% and then said there is no difference. The rest of the 70% patients not studied. Capsicum registry said that fluoropolymer-based drug-eluting stents, this degeneration was noted to be as high as 16.8%. So this study again highlighted this problem of aneurysmal degeneration of the stented arteries, where there is drug elution happening actually, not the drug coating. Eminent trial, halo prevalence was not significantly different between the Eluvia and BMS cohort. That was non-significant. Aneurysm degeneration may be related to FEMPOP artery stents as a class, and that is association with meaningful clinical endpoints has not been established. That is after these studies were done, so that it does not go out of fashion. And that is the narrative that was given to I don't know, no offense meant to the industry, but to shove it off. Then In July 2023, the FDA reversed this restriction as several publications and large data sets ruled out this worse survival. So 2023, the FDA said, okay, this drug-eluting technology can be used, and this pause of 18 to 23 was taken off. That, okay, this can be used, but you have to have larger trials. That is what they said. Then this is the sports RCT. I came across many names, many different kind of names, capsicums and imperials and eminence and whatnot. Sports RCT was a Tepe et al. They said that DES with bare metal stent with a paclitaxel DCB. So all three arms they had in this sports RCT, and they have a 220 millimeter lesion. The mean lesion length was 220 mm that was there in this sports RCT. Eluvia provides superior performance versus nitinol stents and DCB measured angiographically by percentage diameter stenosis, late lumen loss at 12 months, because this was obviously eluting the drug by that time. So this RCT said that in long lesion lengths, this proved to be beneficial with regards to that. Eluvia provided superior outcomes versus these two technologies measured by freedom from TLR up to 12 months. So both in the diameter reduction and TLR in the long lesions, this Eluvia stent was fared better in this sports RCT. Then there was two more different names. Pardon me, sir, for so many trials, but I'll come to this thing. Drastico, Real PTX, single center RCT compared what? Zilver PTX to DCB. The lesion length 146 to 140 mm. 1 year follow-up, DCBs not superior to Zilver PTX. Another Real PTX RCT comparing PTX to DCB. Similar patency rates, non-significant trend in favor of DES. So controversies always existed. What I am trying to tell is that DES is not the perfect thing. As compared to DEB, the superiority has been questioned time and again. That is what I am trying to say here. Esprit trial 2016 Lammer, first in human study of drug-eluting bioresorbable scaffold. Then they said, let's not leave the stent inside. Deliver the drug and let it pass off. Let it get dissolved. As was said in the morning that there are so many things, the nanoparticles, scavengers, various things to deliver the drug. So let's have a scaffold. For external iliac artery and the SFA, they devised this, and they said that 100 milligram of everolimus per centimeter square will be delivered from the scaffold. Sustained patency 2 years, freedom from binary restenosis 87.9%, 83.9% at 12 months and 24 months. But lesion length 35 mm. That is what this scaffold was designed for. So this is when you are reading in between the lines that, okay, you have a good patency rates, but then what are you dealing with? Ongoing trials, ANZ, April 2025, the results will be, the recruitment will be over of a E-femoral 1 trial and Disappear trial, which some things were presented in Charing Cross this year, which is a multicentric trial. E-femoral 1 is from 7 centers across Australia and New Zealand. Disappear has 18 centers across Europe and Australia. That is also a balloon expandable stent with a drug elution that is going to come, that the trials are just ongoing. So this was regarding the FemPop segment. I'll finish up the BTK segment. Sorry for just taking 3-4 more minutes, but well, drug eluting stents in one lecture I have to cover. So just so many stents, so many designs, Cypher Select, Zynes V, everything that you see here are coronary stents. The thing that you are seeing here is an extrapolation of the coronary technology into the BTK segment, and why. They are paclitaxel, everolimus, sirolimus, nitinol stents, stainless steel stents, everything. I'll come to that. But all the trials that have been done, Achilles, Yukon, PADDY trial, Seval trial, IDS trial, Life BTK trial, all these are made for the coronaries, extrapolated on the BTK arteries. Dr. Dhanesh will be talking specifically on his experience on the BTK stents. But if we see, the number of patients are in good range, 200, 140, 161, 137. All they talked about is maximum patency rates 6 months to 1 year, nothing beyond that. So everything that these things talk about, sirolimus, paclitaxel, everolimus, is maximum up to 1 year, nothing beyond that. So in 2 studies, we will see that in 2 trials, the primary endpoints were also not met. In the rest of them, the primary endpoints were met. So were these studies designed adequately? The Achilles trial, well, for exams, you used to study the Yukon and the Achilles trial. Some postgraduates will confer to that. Achilles trial, Cypher Select or POBA, this was the comparison. Drug-eluting stent at 12 months achieved significantly lower restenosis rate. Need for repeat revascularization and amputation rates were similar for both the arms. Destiny trial, Zines V, this is for the coronaries. 12 months, significantly improved. Drug-eluting stent significantly reduced both instant. So every study that was being done at that time was saying that drug-eluting stents in the BTK segment is very good. Yukon trial, Yukon S stent versus bare metal stent, they said 12-month patency 80%, secondary patency 91% in the drug-eluting stent, also change in the classification grade. Paddy trial, which was the Texas Liberty, which was a balloon expandable, all these were balloon expandable stent, 5-year rates of amputation, event-free survival, lower in the DES arm. Now here is where these things start to change. Now this is that drug-eluting stents have lower the amputation-free survivals. Although the results of all previously described drug-eluting balloon expandable stents sound outstanding, the implementation of a permanent metallic scaffold in small caliber vessels could be considered an undesirable downside of this procedure, and that is how the narrative changed with a live BTK trial. When they had a Esprit BTK versus POBA, they said that primary efficacy composite endpoints was higher with the DES. Then came the PES. This is the self-expanding stents. All these stents were balloon mounted. Now this is the self-expanding stent. They said it failed to show a positive outcome with the drug-eluting stent in below the knee region. Saville trial, 12-month primary patency rates were 68% and 76% for the POBA group. Now here POBA is primary patency is better than the stent group. So this is how the narrative starts to change once you have a landmark trial saying no, we were a little wrong because the lesion length was very small. I'll come to the lesion length, and no benefit related to effectiveness and safety with nitinol DES compared with POBA could thus be demonstrated. Concerns, lengths, coronary stents, short stents, cost, okay, you are compared to a POBA, you are putting in stents, you may have to put 2 stents or 3 stents. Higher risk of crushing deformities, where all in the distal half of tibials and in specific anatomical arches where the anterior tibial is perforating the intraosseous. Difficult arterial disease pattern, they say that it's a small arterial disease, medial calcification, big arterial disease with intra-arterial calcium, short length of coronary stents, crushability, flexibility is not there, permanent nature of DES, you are leaving in metal there, and lack of hard clinical outcome improvement. Is it healing the wound? Is the ischemic rest pain being relieved? Are the major amputation rates going down? Or you are just looking at patency? So these are the important drawbacks with relates to this, all these things. So this is regarding the lesion lengths. Only ideas, the bars that you see, the maroon bars that you see are actually the lesion lengths. Achilles, the mean lesion length in mm is 26, Destiny 15, Yukon 30, Paddy trial 21. Only Ideas has a 127 mm lesion length. Otherwise, all the trials are having 30, 40 lesion lengths stents that were used at that time. So what do we mean by that? That better sizing, optimal vessel preparation, maybe the technology improves, dedicated BTK debulking devices are there, plaque modification like we were talking about IVLs in below the knee segment, combination with appropriate, including bioresorbable scaffolds, and a shift towards limus elution, that sirolimus is gradually picking up, that these devices will hold promise in the near future. So to summarize, this is the giant wheels that are there, which I am not sure anybody will be able to crack this code, but if I am to say this, which I have studied, that if you see on the right, there is a FEMPOP segment, on the left, that is the BTK segment. In the FEMPOP segment, if you decode this graph, there are so many arrows running all over, some favoring the bare nitinol stent, some favoring the polymer based stent, some favoring going last towards plain balloon angioplasty also, or drug coated balloon. So there is a round robin happening on the right side. Left side, if you see the BTK, plain old balloon angioplasty, single wire, single balloon, or you go for spot stenting. In some cases, selected cases, this may help you if there are so many studies on the left side. You see PADDY trial, Saville trial, they go for polymer based paclitaxel eluting stents, limus coated resorbable scaffold. So this all, if you go into the sub analysis, you may find your patient that you're treating. So there is no one size fits all that, okay, this is the technology for the future that has to happen. As we speak, the trials are still ongoing with relates to drug eluting stents. So I hope that I have been able to decipher everything, and everything has been answered with regards to drug eluting stents. We all understand everything with regards to the Bombay government that has been made. We understand the Maharashtra politics, and we understand drug eluting stents. Thank you so much for understanding my pun and everything.
Thank you, sir. Due to short time, we would take the questions in dinner.
Sir.
Tapish, you always seem to make me a villain. I'd like to bring out a specific statistic about your presentation. Did you know you quoted from 68 trials in your presentation? I counted them. Okay? If I think, I don't know about others, I can remember even half of them, I would have been an IAS officer. I wouldn't have been sitting over here. No, the reason why I say that, choose a limited amount of trials and drive home the point, like he said at the end of it, it's really tough remembering. Really tough remembering, and we as surgeons, we cannot go into a convoluted way. And all of us have done, whoever has done around 10 years of vascular surgery knows what works, what doesn't work, and where you can stretch the indications a little. So, that's all.
Thank you so much.
You just stopped short of 69.
Our next speaker is a case presentation for drug eluting technology in SFA, Dr. Nihar Pradhan.
Good evening, and thanks the organizers and the society for doing an excellent discussion on a particular topic. Though it was looking like drug toxicity, but they told that it can't be toxicity because a very low dose it will come. So after all this discussion, where we go from where? So where do new procedure and devices fit? So this is a patient, 73-year-old male, hypertension, diabetes, coronary artery disease, post-PTCA, left leg critically ischemia therefore 5, with non-healing ulcer over the left great toe, plantar aspect. Pre-procedure pulses, common femoral artery palpable, distal not palpable, ABI was 0.3, CT peripheral angio, critical stenosis of left leg. So here we used 5 into 80 millimeter mosaic drug eluting balloon, where this was the effect, and after a few weeks you can see the result. So these cases we have done last few months into the 2024 only. The second case is a 51-year-old male, diabetes, left leg critical limb ischemia, but ABI was 0.8 because of calcified blood vessels. So here, because the patient was not interested for any intervention, somehow we convinced because of insurance also was there good. So we used straight away drug-eluting balloon, same 6 into 80 mosaic drug-eluting balloon. So post-procedure ABPI was almost 1.1 plus. There is some dissection over there, but patient was okay and could discharge and follow up last 3 to 4 months. This is the third case, which is again 59-year-old male, type 2 diabetes. He was a chronic smoker also before, and left leg critical limb ischemia with gangrene of grade 2. But both legs were diffuse atherosclerosis, and the claudication of the left leg claudication distance came down from 1 kilometer to 50 meter within 2 months. So because of history of smoking was also there. So peripheral pulses distal to common femoral artery was not palpable, and CT peripheral angio was showing diffuse atherosclerosis. So here what we did, we thought we'll use fast hour ETO balloons so that to save some money. And what we did, here we used 4 into 100 m Armada peripheral balloon catheter, followed by, so this is the result we got. Then again we used 5 into 100 Mustang peripheral balloon just to increase the 4 mm to 5 mm, and because it was ETO available in our lab. So then we could not find the better result. Yeah, you can see here after the second balloon. Then I thought too much. Now we have to use the drug-eluting balloon, convince the patient, yes, we'll use this. So this time we used 5 into 150 impact Admiral paclitaxel drug-eluting balloon from Medtronic. That was, and these are the studies just added to our tapis. So these are the future ongoing studies. And so the key takeaway is the primary goal is for the, as we discussed last 2 decades, what the way of management, good medical therapy with all these things additional definitely will help. Thank you. Any question?
Thank you, sir. Let us, we'll proceed with the next session. I kindly call upon the chairpersons for the next session, Dr. Gnaneshwar, Dr. Vineet Paliwal, and Dr. Nikhil Sharma to come in front. And Dr. Sunil Rajendran will be talking about, is POBA still relevant in the SFA? Quite an interesting topic.
Good evening, and thank you, Vessomag and the organizers for this opportunity. I know I'm standing between banquet dinner and end, but yeah, but most of the what I wanted to present has already been answered by Raghu and the discussion we had already. I think when Shekhar sir called me to talk on this drug elution, I said, frankly, I don't do any drug elution. So he told me I don't talk about not using drug elution. I thought, okay. So it's an opportunity to pull up our own data and just discuss in meetings like this. So basically what I did was I just pulled up my own SFA data of last 3 years, and I'm just going to present my data. It hardly takes 5 minutes. So basically in India, when you think about POBA, we think about simplicity, availability and affordability. And especially I come from Kerala, where people are very, very cost conscious, and they are very much conjuice about when it comes to health. medical treatment. They will spend on anything else but not on health. And so I thought we'll just evaluate our SFA intervention. So our institutional practice is basically we do POBA as much as possible and it's plus minus stenting in only major dissections. And we just follow the patient with clinical outcomes. Most of the time we don't do duplex in all patients as most of us do. Feel the pulse, check the ABI. Only wound healing is bad or something, we again recheck and do some second angiogram, etc. So technique is standard, like we go antegrade in most patients, use vert and all those things, cross intraluminally as far as possible. Otherwise, go subintimally, do POBA with 4, 5, 6 mm semi-compliant balloons, and sometimes even NC balloons also of late in calcific arteries. Use of stents, basically calcified arteries, we rarely use cutting balloons or scoring balloons. And if there is flow limiting dissection and definite recoiling, we use stents ranging from self-expanding, usual stent, whatever is available in the cath lab. I'm not very specific about any particular stent, even sometimes a covered stent, graft mask, coronary stents, etc. And technical success parameters is basically based on the flow in the angiogram suit, and if there is palpable pulse, I'll be more than happy. Post-procedure, put patient on dual antiplatelets, select use of DOACs, but I tend to use prostaglandins in many patients whom I think results are suboptimal. I don't know whether that influences my outcomes. Follow-up is basically by wound healing, palpable pedal or popliteal pulse after SAV intervention. So going to my results, like over last 3 years, we just did around 100 cases of SFA angioplasty, which includes isolated SFA as well as SFA plus iliacs and SFA plus tibials. And basically, most patients come for follow-up. We have got reasonable good and good follow-up culture in our patients. And those who cannot come, we call them up to at least find out whether they're alive, the limb is safe, wounds are healing, etc. And we got 91 in follow-up. These usual demographics like more males, average age of 67 years, diabetics mostly, etc. So access, as I told, mostly ultrasound guided, only 5 cases retrograde, almost 86 cases we went antegrade, and of which 39 CFA puncture, 46 SFA puncture. We do little bit SFA puncture also in our SFA plasties. Average length of lesion, I just looked at, it's not bad, about less than 5 is 31. And we had good reasonable spread of length of lesions in the SFA bed. Immediate success is actually in almost all patients except one, we could cross the lesion and do some plasty. We stented only around 20 patients, that is around 21.9% of this series. Stents used, as I told, nothing specific to any company, whatever is there in the cath lab, I tend to use, like Absolute Pro Epic, Everflex, 1 graft master and 1 coronary stent in a small SFA in a female patient. Follow-up, we had decent follow-up of around ranging from 12 months to 36 months. We had to do bypass in 1 patient after POBA. 15 patients died due to unrelated causes, 3 major amputations, and wound healing achieved in 94.6%. And Kaplan-Meier, actually, I just pulled it out last week, had a decent survival curve at 24 months. Actually, the difference between the statistics which we see in the studies which have been quoted here is that we have most patients Rutherford class 5 and 6 because we obviously don't treat claudicants. And technical success rate is almost equal to almost all the studies quoted here, like 98.9%, and limb salvage is not actually bad at 94.5%. Like Raghu said, none of the studies actually talk about amputation-free survival. They talk about patency, TLRs, etc., which actually doesn't boil down to patient when they come to us in the clinic. They are just bothered about having a healed wound and they had to be amputation-free. Just looking at just 2 studies, just to highlight what actually are the flaws of these studies. If you look at this one of the major studies, they have got most patients in Rutherford 2 means I think mild claudication, 3 disabling claudication. The most patients are in mild claudication and disabling claudication. There are hardly any patient in Rutherford 5 or 6. And that is what the data they're talking about patency. That is, they talk about patency 79% versus 46%, which is actually not clinically significant. And they talk also about target-driven TLR, which also actually practically, when it comes to clinical practice, it's not actually significant, and we won't push our patients to angioplasty just because they have a lesion, we don't go and put in balloon or a stent. Again, another big study, because this study published data of around 1,400 patients. Again, if you look at this study, hardly any patient Rutherford 6, just 1.5% of patients in Rutherford 5, most patients in the Rutherford 3, that is disabling claudication, which actually we wouldn't actually treat or intervene in most of in our clinical practice. And they also again analyze data like freedom from TLR, primary patency, device-related complication, etc., which actually is not a matter of concern for a patient with CLI. And actually, we wouldn't actually look at all these things. So actually, whatever in the study is not clinically relevant when you talk about CLI patients when compared to claudicants. So in my personal observation, I found that not much data on patient with CLTI, even though I think Chaitanya told me about that. There's one study. I just went through the net. I found that study was particularly about intrapopliteal, not about SFA. So if Basel 3 comes out, that will be the first study which actually deals about DCBs in CLTI. Otherwise, we don't have any hard data about use of DCB in CLTI. And most data does not look into limb salvage as a primary endpoint. They talk about TLRs and primary patency. And in CLTI patients, drug elution might not significantly impact the ambulatory survival rate. This slide was prepared before Raghu's talk, so don't think that I modified the slide after Raghu's talk. So obviously this slide was there. So drug elution seems to have a definite place in claudicants if you want to treat them, which we most of us don't do. And in CLT patients, I think selected group of patients like treatment of in ISR, redo intervention, and small SFA where you don't want to put stents because SFA is small, you might use DEBs and they may be useful. But if you really ask me, you can use the technology selectively, but you cannot actually prescribe this as a blanket practice for all patients in our scenario, at least in India. So I think with this, thank you for this. I think I summarize what we discussed over the day.
One question is, your balloons are ox or are they all new? What is the status of your balloons?
Ox.
All ox.
Not ox, it depends. SFA balloons are mostly ox.
Okay. The other thing I'd like to comment on your general perception is that some patients may accept claudication. Some don't, like the class of patients who I treat will not accept claudication. You may say your wound is healed, so what if you are not able to walk, but once your wound is healed, you want to walk more. So they don't accept claudication. And would you agree with that? What is your experience?
Can I make a comment? I just want to give a frank question. How many of your fempops have died due to surgery? Touchwood, so far none of my fempops have died after surgery. So we are really afraid, and we quote Western data saying that the mortality is what is keeping us back from doing surgery in patients who are claudicants. So actually, if patient has recurrence after primary intervention or he is a disabling claudicant, we can always offer surgery, which will give us like 10-year patency of like 80%. So why we debate always about stent balloons in claudicants and even CLTIs, when we can do fempops, and we hardly have any mortality in fempop, even if patient is having cardiac, even if patient is cardiac sick. That's my take.
So a couple of comments. I think it's fascinating that you've got data here that's showing you got a 15% 3-year mortality. So in the CLTI group, I think this is something we all need to remember. Even in India, there's a very poor survival outcome. This is as bad as some cancers, realistically speaking, and that's something which a lot of us tend to forget. So when they're looking at 5-year patency for an Eluvia stent, that really is relevant, like you said, to the claudicant. And like Shekhar said, I would agree, there are patients who want treated for claudication. Today, maybe our practice is 90% CLTI. 5 years from now, the patient profile is going to change, patient expectations are going to change. We are going to have to deal with claudication that wants treatment and a better quality of life. So maybe we do need to be aware of how this technology works in that. So that is relevant. Bypass is, 80% 10-year patency of bypass, I think is a bit optimistic. I think literature you will
not 80%, maybe like, it's not bad actually. I think none of our bypass.
Vein bypass, fem above knee, best places would be about 80% at 5 years.
Yeah.
So, I think, and looking at the kind of patient profile, they're going to start getting older and sicker. So I think there is going to be issues even with that. That's just my comments. But it's fantastic, the data you've shown.
No, but DEB definitely has got a role in claudicants, but not in CLT. That's the gist of the presentations and what talks we had. So maybe in claudicant, if they want to get us intervene, you can suggest DEBs in those subset of patients, not in CLTs.
If you're looking for long-term results, DEB helps. But if you require wound healing, you certainly need your POBA as your mainstay, isn't it?
Yeah.
If you have somebody who's going to take time for wound healing to take place, so then it's not that POBA is irrelevant, just doing POBA and leaving it. But if you have somebody like, it's going to require 6 months for wound healing to extensive, then it depends on it depends on the situation. I mean, you would probably use a stent if there is a dissection or something like that. So I've had couple of cases where huge wounds, means that from the calf, proximal calf, right down to the heel, because this was a diabetic neck. Actually, she's my friend's sister. And we've had to intervene not once, but 3 times, because put a stent, stenosis. The other side, she had a very small wound. I just did a POBA, and wound was looking after the wound very carefully. Plastic surgeon, I was not there for some time. Little tight bandage, wound became severe, ended up with gangrene in that area. Explored, not explored, but did the angio, re-stenosis. So here I put Eluvia, and things started improving. They did a skin graft. One small part was not healing. Again we checked. We found that that eluting stent, bang, open, but there was disease beyond that. So point is that there are some situations where that it's going to take a long time to heal. So you want something which is going to last till that wound heals.
In redo and ISR, definitely DEBs has role, but in primary intervention in CLT, the DEB does not seem to increase the outcome, clinical outcome, and ambulatory survival basically.
Sunil, excellent follow-up and good study. We have to collect more data into it. But I do I agree with the Shekhar. That is, some claudicants you have to treat it. When we go for the IR conference, they are treating all claudicants. So we cannot simply deny them. There should be a consensus that we should treat them medically for a particular period. And if they are not responding to it, we need to address them, because life-limiting claudications are very difficult to tolerate also. They also need some attention. Yes.
Just one last comment. Almost all these big studies have been done by either cardiologists or IR guys. All this big, I just found all reported in cardiology journals, not in vascular surgery journals. I am not sure. And just my observations, which I saw today morning.
Okay.
Thank you, sir. The last case presentation of the day. Would invite Dr. Shashank to present a case of thrush in popliteal artery disease.
Good evening, everybody. I am presenting a case of 69-year-old diabetic male with a history of TMA of left foot done in 2020-22, presented with dry gangrene of left 4th and 5th toes extending just beyond MTPs on plantar and dorsal aspect. On examination, bilateral femorals were palpable, popliteals and pedals were not palpable, no Doppler signals on the right, left PT biphasic signals and AT monophasic signals. ABI showed 0.54 on the right and 0.93 on the left. ABPUG showed dampened waveforms on the right. Wi-Fi classification suggested high risk of amputation without revascularization, and potential benefit of revascularization was also high. So we went ahead with on-table angiogram and proceed. Angiogram showed non-flow limiting stenosis of distal SFA and P1 popliteal non-flow limiting stenosis, P2 chronic total occlusion. P3, there was short segment stenosis just above the bifurcation. Peroneal was the dominant flow into the foot, forming collaterals to the ATA and PTA, which were diseased. So we went ahead with popliteal atherectomy with jetstream device with good clearance. But post atherectomy, we found out trash into the peroneal artery, which was the only remnant supply to the foot. Using 4 French vertebral catheter and 50 ml 50 cc syringe, we aspirated the trash, post which there was good flow beyond the trash segment. Following that, we did popliteal angioplasty with TCB, paclitaxel coated. Post procedure, there were biphasic signals in DP, PT and peroneal. Pedal acceleration time was 120 milliseconds in PT area. So we went ahead with TMA of right foot. There was poor wound response after 14 days, and though the ABI showed improvement and PAT was still 120 milliseconds, there was poor wound response, so we had to take him up for repeat tibial angioplasty. This is the latest status of the wound taken on 7th December. For the popliteal and tibial disease, we had 3 treatment options. One was intravascular lithotripsy using atherectomy devices and femorodistal bypass into the distal PTA. Reasons for choosing jetstream atherectomy: mixed pathology of calcified and atheromatous disease, knee joint stenting difficulty, CTO lesion in P2, and to prepare bed for DCB. The possible complications were already listed, and we have encountered the embolization. Distal embolization prevention strategies using distal filters, slow atherectomy, continuous aspiration, low profile device use, and multiple pass techniques. Take home message: atherectomy devices are effective for debulking plaque in peripheral arterial disease, but patient selection, proper planning, and appropriate adjuncts are essential to maximize benefits. Thank you.
Thanks a lot, Dr. Shashank. We are at the end of day 1 for the scientific session, that is. Kindly join us at Sun and Sand, Juhu. We'll be having dinner there from 8:30 onwards. There are vehicles down to take you to the hotel, and from the hotel we'll be taking you to Sun and Sand. Thank you.